Good morning, everyone, and a very warm welcome to the present evening. So, today we will be discussing the NIV and its physiotherapy perspective and interventions. So, this is a very new topic as far as the physiotherapy department is concerned. So, why we are discussing NIV today is because one reason is in last decade in our physiotherapy unit we have seen an enormous use of NIV, and it is increasing day by day. Partially, otherwise also, not just in the CTVS, the NIV use has already increased. Partially because the technology has become so advanced that machines have become very affordable, very efficient, and very compact. And also, on the other hand, there is a new advancement in science and technology has led to the new changes. A new subset of patient has come up these days, where the surgical procedures and other techniques which were denied to those patients are being taken up. For example, the patients with low ejection fraction, the patients who are aged, and patients who are with comorbidities. So these new subset of patients becomes the potential candidate for the use of NIV. Also, as the use of NIV has increased, so as the body of literature has also increased. There is an enormous research now on NIV, and most of them who are here will also agree that there is a conflicting research. Many a times you see the articles somewhere they will say the indications are there, some say the indications are not there. So whole of this environment, we choose to discuss this topic of NIV. I know this present scenario, there are a lot of questions related to NIV, and this current CME is an attempt to answer, not all if possible, at least some of them. Some of the crucial questions will be answered. That is the aim of theme of our NIV. And today we are very lucky to have Professor Shri Shiv Kumar Chaudhary sir, who is our HOD, and he is here with us. And this CME is actually is his thought. He is always keen to spread the education and the learning at zero cost. So in this, taking his idea, taking his thought forward, this CME is without any registration fee. Sir has done it. Sir regularly has been doing in the CTVS department. So to carry this forward, this is a time when we are doing it here. We have done it in the past also, and under his umbrella and under his guidance, we will keep on doing this further on. So with this, I request Shiv sir to just please address the gathering, this esteemed gathering. Kindly come forward, sir, please.
Good morning. I will not address, rather I will talk, because when it comes to question of addressing the class differentiation, somebody is ignorant, somebody knowledgeable. That is not the scenario. You are much more knowledgeable in certain field. I have some knowledge in some different field. So it's basically a talk. So what's the need of this type of focus CME? I keep on encouraging that what Sachin told. If we see we should understand the basic difference between information, knowledge, and wisdom. This platform is to share the wisdom. So what's the difference between information? Information means some facts about a particular thing. When you go for a Google search, what you get information, lots of information. When you arrange it systematically, something comes out of it, it becomes knowledge. But when you apply, in what direction can you use that knowledge for the for beneficial purpose or for destructive purpose? That becomes the wisdom. So if I give you a simple example, think of knife. Knife, as far as information goes, there is a knife, it cuts. That is information. Okay. So then if we go to the level of knowledge, systematic arrangement of it, we will come to know that, okay, knife can cut human body also. That is knowledge. But we can use the knife to cut human body in different manner. We can use surgically also, we can use the knife to stab a person also. But if we say that knife can be used surgically to cure ailments to benefit the mankind, this is wisdom. So this type of workshop are basically wisdom sharing. All of us have a wisdom in a particular field. When we sit together, when we talk to each other, we share that wisdom. So that will benefit all of us. The person who is standing here talking or somebody who is listening, that difference goes away as you will proceed, and it will be basically a wisdom share. And the wisdom and knowledge sharing, and not only sharing, it's acquiring. First stage is you acquire that wisdom through the knowledge, and then you become the master to share, master or say tool to share that wisdom and knowledge. Because in our life, somebody who is having some spiritual background will understand that when Krishna talks about Karma Yoga, he also says that it's the way to attain godliness is through Gyan Yoga also. In our Upanishad and Vedas, you will find that the seeking the knowledge and wisdom is one way of becoming God. If you are in pursuit of knowledge and wisdom, that leads to godliness. And we should not go away from that attitude. We should always be knowledge seeker, whatever may be our stage, because that leads to perfection. And when you become perfect, you become closer to God, or you become just like God. I can suggest a small book. If you people, most of you people would have read that book. It's Richard Bach has written that book. Small book, very small book, say half an hour to 45 minutes. That is Jonathan Livingston, The Seagull. That is the whole title. I would not narrate the content of that book to you people and will not destroy the climax of that, but read that book and follow that book in your life. So I will just stop here, and I hope this workshop will be a good platform to share the wisdom, and this collective wisdom will definitely benefit all our patients. Thank you.
Thank you, sir, for motivating us, all of us. So, we all know that the use of NIV is a first line of intervention, especially in the patients, selected patients who are hypercapnic respiratory failure. And also, we are aware that the use of NIV, it can prevent intubation, it can decrease the length of stay in ICU, and it can lead to the early recovery of the patient. Despite this, we have seen the NIV use is often limited by the patient's tolerance, whether it's a tolerance of the interface or whether it's the tolerance of the positive pressure. And most of the time, it leads to the treatment failure. So, continuing this CME, we will like to start to minimize, to know some of the predictors of the success so that we can minimize these failures. To continue this talk and to show some light on the predictors of the success, I request our first speaker. He is a distinguished speaker, Dr. Sarvesh Pal Singh. Sir is the Associate Professor in the Intensive Care Department of CTVS. Sir, we are lucky to have with us, and today Sir will be throwing some light. So what are the predictors of success so that we can minimize our treatment failures? Please welcome.
Good morning. Good morning. So we'll begin with a topic which I try to simplify to my level best. When actually you look for data, and level of evidence and quality of evidence, when we talk about non-invasive ventilation in cardiac surgery, it's not much. Moreover, most of them are retrospective studies on less number of patients, because assume a post-cardiac surgery ICU of 18 or 20 beds, out of which maybe 20% being emergency surgery. Out of them, a subset requiring non-invasive ventilation, the number actually comes down very low. If you look at best of the data available, the patient numbers would be in ranges of 50s to 100, somewhere in between. And these are large studies I'm talking about. Smaller studies have patients hardly of 8 or 10 patients who underwent non-invasive ventilation after cardiac surgery. So we'll just try to see what statistics we have in pertaining to cardiac surgery as of now. So the incidence is somewhere around 5% of all the cardiac surgeries which require non-invasive ventilation. And this is pertaining to patients who underwent cardiac surgery, were extubated, and then required non-invasive ventilation. Then there are studies in which the median duration of initial mechanical ventilation were in ranges of 1 or 2 hours. I have deliberately not put it on board because we are not sure what were the indications for putting those patients within 1 or 2 hours of extubation. Maybe the criteria was wrong. This was a study which I have quoted. This was a 63 patient study out of 1200 patients over a period of 3 years, in which the initial duration of mechanical ventilation before they put the patient on non-invasive ventilation was somewhere around 38 hours. Similarly, the duration after extubation, during which the patient was on spontaneous ventilation, was somewhere around median of 40 hours. So what I'm trying to say is they ventilated the patient on mechanical ventilation with a ventilator for 38 hours. Then the patient was spontaneously breathing for 40 hours. And then for XYZ reason, they put the patients on non-invasive ventilation. This simply translates to that for 1.5 days, the patient was on ventilator. For 1.5 days, the patient was, or approximately 2 days, and then 4th day of surgery, for some reason, the patient went on non-invasive ventilation. As such, it speaks volumes that it will be a difficult case to manage to begin. No doubt that 50% of these patients got reintubated, and out of those 50%, they had a 50% mortality. But one thing we can say for sure, with surety in this study was that these patients did require non-invasive ventilation because there was a considerable dying between extubation and non-invasive ventilation. Overall mortality in this subset was approximately 30%. A basic terminology when we talk about success of any intervention for that matter, not only non-invasive ventilation, is what actually are we trying to define as success? Are we trying to prevent intubation per se altogether? Are we trying to continue non-invasive ventilation for a particular duration of time, like predetermined period? Suppose I extubate a patient of CABG, the patient goes into acute LVF. Now I know that I can manage this patient easily with diuretics, but I need some kind of bridge to prevent intubation. So I predict that for 12 hours, we will put the patient on NIV, do aggressive diuresis, start infusing. And by that time, the patient should be all right, so that we should be able to wean the patient off NIV. If I am able to achieve that, is that success? Or if I am able to achieve that earlier than that, is that success? Or if you determine a particular period, like 24 hours, you want to keep a patient on NIV, and you are able to do that without triggering any adverse event. This type of definitions are actually used for ECMOs, in which the quality of the program is never judged by the outcome of the patient. The quality of the program is judged by how much complication you encountered when you instituted a particular therapy. Or the patient has to improve on non-invasive ventilation. Is it mandatory? Because if you are not treating the pathology, there is no way the patient will improve. Or outcome variables, like Dr. Sachin was saying, that it has to decrease the length of ICU stay in ICU, length of the stay. Success by virtue of the term means the fact that you have achieved what you want. So whenever we talk about non-invasive ventilation, there has to be an endpoint which it should be determined before you start it. It may be whatever you start with. It may be simply avoiding intubation. If you're confident that you have extubated the patient on a right extubation criteria, there is no other complication, then it should probably avoid intubation. At the same time, probably you have extubated a patient who has an intervention tomorrow again, or probably something else, and you want to just tie it over a duration of 12 hours. If you can achieve that, that is also fine. That is success with NIV. Sorry. Now, before we go to predictors of failure and success, failure always precedes success. Just because we are succeeding in each of our attempts does not mean that people preceding us one did not land up with failure. It is because of their failures we are landing up with success in each and every attempt. But before that, and this decision making will influence whether your intervention is going to be successful or not. What are the decisions which will influence the factors which will influence your decision making when we are talking about putting a patient on non-invasive ventilation? The pediatric part I will not deal with. I just mentioned this, that age of patient is a major predictor. A 3-month-old child extubated during night or self-extubated during night, having 4 inotropic support, borderline urine output, I will probably not put on any. Same patient extubated electively during day, only 2 organ dysfunction, optimal cardiac output, maybe yes, I will give a try. So decision making depends on the patient profile. One, if you select the appropriate patient, they are more likely to receive. The availability of expertise versus trained manpower. Availability of a physiotherapist is expertise. Availability of a nursing officer who can put a patient on NIV and a resident to oversee is trained manpower. The difference is if you are taking a decision in a gray zone, you need an expert. If you are taking an elective decision, I will come to the last slide to differentiate it better. If you are taking it on a probably on a safer side, trained manpower will do the job. Time of the day, I already said. The status of other patients in ICU. If you have an 18-bedded ICU and a one team leader, if 4 of your patients are borderline, one is about to go for re-exploration, one is about to go for a IABP, the other has just been revived from cardiac. Worst idea is to put a patient on a gray zone on NIV. Elective cases operated, hemodynamic stable, heart rate stable, respiratory just a bit 25-30, yes. 2 organ dysfunction and 4 sick patient, not best of the ideas to put. You are bound to fail because you will not be able to give 1:1 attention. Hardware availability, obviously, the hardware is made according to the mean, median age, the different features of patients according which you can give an IV. So it is not possible to have the exact fit of hardware to all of the patient at all points of time. Then comes the nurse to patient ratio. Usually we have a 1:1 ratio, but it may not be true at all points of time. Sometimes you have festivals around that, sometimes you have a disease coming around, viral fevers. These are the times where you will have less nurse to patient ratio. So decision making should be, if you're putting a patient on NIV and more so with for a right indication, it should be 1:1. And if you're expecting a new onset of complication, suddenly just after extubation, if your patient has landed up with pneumothorax, this is a treatable cause. You can try it over with NIV, put a chest tube in, and then take it out. Similarly, if you have landed up with something more sinister like a tamponade, not best of the ideas to put it on NIV. Then comes the factors associated with failed non-invasive ventilation. Obviously, like I said, if your patient is requiring a long-term NIV in immediate post-extubation period, like you extubated the patient and now the requirement for NIV is 12 hours, and this is unexpected. If you have planned it, it is well and fine. But in an unexpected manner, if the patient requires somewhere around 12 to 24 hours of non-invasive ventilation immediately after extubation, it is probably not going to sustain. Then comes obviously diaphragmatic function. Altaf will talk about it later on. Pneumonia, early onset pneumonia is bound to have bronchospasm and other reactionary airways. In this case, it is very unlikely that the NIV will work because it's an evolving pneumonia. First 48 hours, the pneumonia will keep on evolving and it will be a progressive pneumonia. Not best of the ideas to put the patient on NIV. A stabilized patient who has already developed a consolidation is being treated and is now resolving, or maybe not resolving on a plateau phase, yes, NIV may work. Long-term patients having sternal complications like unstable sternum, infection. In our setup, post-cardiac ICU, hemodynamical instability is like practically universal. All patients who are requiring some kind of ventilation will have some kind of hemodynamic. It may be ectopics, arrhythmias, simple bleeding, infected wounds, tamponade, things like that. Then the patient's compliance. The patient may be delirious because of excessive opioids, may be agitated for some anxious reasons, pain, repeated surgeries, long stay in ICU. Patient, if I stay for 5 days in ICU, I will go crazy. So patient compliance with the machine and with the instructions is important. A patient is not compliant to instruction or hardware, we are not likely to success with this. Dialysis dependent acute renal failure or acute liver failure, again, factors for failed intubation. Normally, if the patient is requiring continuous non-invasive ventilation for exactly 48 hours, I would probably intubate, whatever the cause may be. If you're not able to remove the mask of the patient even for 5 minutes, 10 minutes, or half an hour for him to feed or do his normal activity, this patient is not meant for an IV. This is some distribution based on a study in which they try to study causes in post-extubation acute respiratory failure, where they found that most of the causes, the predominant causes between 1 to 48 hours were something like you had a hemodynamic instability, intolerance to psychomotor, agitation, and weak cuff reflex, like diaphragmatic function. If you keep your patient continuously paralyzed for 4 or 5 days and then try to use an IV, it will be a tricky course. Because every time you keep the patient paralyzed for 24 hours, the diaphragmatic function comes down by 10%. This is what the literature says, and theoretically, I'm sure Altaf will have more insights in this. So one of the factors which is that if 4 or 5 days mechanical ventilation, continuous paralysis, you can mechanically ventilate without paralyzing. These patients are going to do better than patients who are being continuous paralyzed. So we try at all levels, at all costs to avoid paralysis. Now comes the exact topic, and this is the smallest slide in this whole presentation because the evidence per se and the quality of evidence per se is extremely low. Appropriate patient, and depending on the factors on which I already enumerated, the decision making should be made. It will determine whether you are likely to succeed in the near future when you are instituting an IV or not. A predictable use of non-invasive ventilation after extubation. Decision before extubating the patient to NIV is more likely to succeed than using an IV in an unexpected scenario. In an unexpected scenario, using an IV has been shown to delay intubation and actually increase mortality. And expected planning will decrease intubation and mortality. So if you are going to put a patient on an IV, it should be decided before extubation. Obesity has got excellent outcomes when you are using an IV in early period, because these patients are having atelectasis, more atelectasis because by virtue of their pathophysiology. Similarly, cardiogenic pulmonary edema has got excellent outcomes when NIV is used for transient periods of time. And this is excluding MI patients. This is only heart failure patients who have developed acute LVS, and they will resolve once you have given diuretic. Respiratory disease patients, they tend to have good outcomes with lower duration with non-invasive ventilation. Two things apart from this is that once you have instituted the patient on non-invasive ventilation, there are parameters which will tell you within first 2 hours that this patient is going to improve. You put a patient on NIV in a post-surgical ICU with a 70 PCO2, the patient is good compliant, your respiratory rate has come down, this patient is probably going to improve with an IV and will give you enough time to make a decision making or improve enough that you will be able to take it off. If 2 hours have passed without any changes in your ABG, your pH is still hovering around 7.2122, it may be a good idea to revisit the decision, not necessarily intubate, but revisit your management and decision making because something is not going right with this patient. Severe acid-base disturbances like pH less than 7.2 and for a sustained period of time, 1 or 2 hours, bad idea to put a patient on an IV. This patient is not going to improve. Something has gone drastically wrong already. These patients will also have some kind of corrections, and the metabolic milieu will has changed by now so much that it will not be able to treat this patient with an IV in next 2-3 hours. This is an interesting paper which is not on post-cardiac surgery patient. This is simply a COPD patient with exacerbation. The thing I am trying to point out here is that for post-cardiac surgery patient, he should have some kind of this value, and probably with this idea we'll go forward and study in our setup that which were the non-in patients who were on non-invasive ventilation and actually fared well. Because in this paper, they compared non-invasive weaning failures and success in terms of the rapid shallow breathing index, the tidal volume the patients were generating, the minute ventilation the patient was generating. So any RSBI between 30 and 50 on non-invasive ventilation, because when you are weaning from them, you should have some kind of criteria. So any RSBI between 30 and 50 on non-invasive ventilation is this NIV is going to be a successful weaning. Then tidal volume somewhere around 400, minute ventilation 8 liters. These are the parameters which actually predict that this is going to be a successful weaning from NIV rather than an intubation. Unfortunately, we do not have, at least I was not able to find any data in terms of post-cardiac surgery patients for in terms of these parameters. But it would be a good idea to look in our setup that how these parameters change. This slide I've just prepared for one reason. Dr. Umaid and Dr. Bunty will be talking about predictors of success in children. This interesting study enrolled 80% of children who actually had normal oxygen saturation and respiratory rate at the time of application of BiPAP. So this quality of evidence, this type of studies and this quality of evidence is not necessarily applicable in patients who are requiring actually BiPAP for real reasons. Because if the patient respiratory rate is not high, the patient's heart rate is not high, and these are children between 1 to 14 years, 1 to 18 years age group. So if that is not changing, it is difficult to say how much of them actually required a BiPAP to begin with. Thank you.
Any questions, please? So one thing I want to know, sir, how important it is to, I mean, decide about the endpoints before just starting the. What are the endpoints? How can we decide about the endpoints? We are just deciding to institute an
Endpoints in the sense?
in the sense the outcome endpoints, like what we are expecting putting the NIV.
You shouldn't. The outcome endpoints are meant for the patient as whole. One therapy cannot decide the outcome endpoint. Like I said, if you have two organ dysfunctions to begin with, the outcome will not be decided on one organ. You can decide outcome points for the therapy itself. You can put cutoffs that I will give a trial of 12 hours, 6 hours. This is the pH I want to target. Probably this is the improvement I am looking for. This shadow in the X-ray should vanish. These are the therapy endpoints that you can target. Patient outcome endpoints you cannot target with single therapy. If your patient is undergoing a kidney shutdown, whatever NIV you set is going to develop fluid overload and the lung will be wiped out. So therapy endpoints, yes. Patient outcome endpoints, no.
Thank you, sir. See, whenever we are using NIV in our setup, so generally what we do, we are putting a patient, an awake patient, with high pressure, and most of the times there is a very tight fitting mask which is fit to the face. So what happens is when there is a prolonged use, the patient is prone to get skin abrasions, or with this high pressure, it is also associated with gastric insufflation, and the NIV, prolonged NIV use with high pressure is also associated with patient and ventilator asynchronies. So all this is combined effect lead to the removal of secretions is another question, and also the nutrition becomes the another questions when the patient is on NIV. So how a physiotherapist is going to handle these challenges? So now I welcome my colleague Ruchika. So she will be taking care from, and she will be addressing some of these issues in adult patients and how to rectify them. Please, Ruchika.
Good morning, everyone. I'll take just 1 minute because I was just amalgamating what Dr. Sarvesh was talking about, which is actually done in the ICU, the decision making, which precedes when we start intervening on a patient on NIV. To my colleagues who are there from other departments as well, I can see from IRCH Neuro, instead of compiling a relationship of physiotherapy and NIV only in cardiac surgery patients, I've tried to put up my work and tried to find out the studies with the words physiotherapy and NIV. So which means I'll be talking about individual connotations and the role so that you can benefit in your departments, number one. Number two, in cardiac surgery, most of the conditions that we face, like in one case, we find multiple issues. Like the patient is diabetic, patient is obese, as he was talking about, and so many other things that he has already talked about. But what we see is an amalgam of everything, so many things in one patient. So let's move on. How do we? Sorry. Next slide. Next slide. Thank you. So starting from the very basics, that what are the aims of a respiratory therapist? Though we are all physiotherapists in CTVS ICU and we deal with the physiotherapy part of every patient in detail, including the limb physio, but here we are going to target only the respiratory part of it. And as a respiratory physiotherapist working in ICU, the main target of getting a physiotherapist onto the patient is to reduce the breathlessness and work of breathing, which is most important, then improving the efficiency of ventilation, mobilizing and aiding in expectoration of secretions, and maintaining or improving exercise tolerance and functional ability. Can you all see? Okay. Then to achieve these aims, physiotherapists have frequently used positive pressure devices. Most of us are aware that we are using even Acapella. That is positive pressure devices, and there was something that when this topic was put up, I too found it a little strange. But then when I took up the literature review, I found out that in the history of use of NIV, it was a physiotherapist who first published literature and propagated about the success of NIV in patients, which I'll be talking about now. So NIV as a therapy in its own, as Dr. Sarvesh clearly pointed out, that NIV is a therapy in its own right. But more or less, it is used in conjunction with other physiotherapeutic techniques, which I will be shortly telling you why the evidence favors that not only it is needed, but in a way it is mandatory, kind of. Then NIV offers the opportunity to enhance treatment programs and improve patient outcomes, which he just told that instead of just the parameters, it is the patient outcome that we are targeting to improve, that NIV offers that. Now coming to this was a little eye-opener for me. I had been using NIV in ICU for so long, but for this presentation, when I went through this, so I found out in the last of references, I have number 4 to 8, where Suleiman, which is the basic book of Bachelors of Physiotherapy, they have talked about this in 1986 or 87. They had published one article first. Then non-invasive mask ventilation was first introduced in its current form to treat patients with chronic hypercapnic respiratory failure was the first thing that they did a case study on a patient which required assisted ventilation during sleep. The success of this, physiotherapists were actually playing a pivotal role in introducing this technique and demonstrated its clinical usefulness. You know what happened? The clinical success of this technique in chronic respiratory failure saw its subsequent application in patients presenting with acute hypercapnic respiratory failure, which was something for me. How many of us are aware, even those who are using NIV in ICUs? Maybe history. For me, it was like, oh, I didn't know that physiotherapists only did that. Maybe because we underrate ourselves, our HOD, everybody. I mean, I'm really proud to be a part of an ICU or a care where the humble surgeon says that I am one of the expertise you have in other. And this is just not in words, it happens in action. And when my preceding intensivist tells me that you need an expertise physiotherapist, he really means that. The moment he decides that the patient is to be put up on NIV, he doesn't tell the nursing staff to do that. He just tell the physiotherapist to. So we start with not only implementing the NIV therapy, which is an clear indication. Now please go ahead, plan it out, because the favorite logo of our department is planning to fail is like failing to plan, and failing to plan is planning to fail, something like that. So the moment we institute NIV, the whole package starts. The clinical success of this technique in chronic respiratory failure then saw its subsequent application in patients presenting with acute ones. Again, physiotherapists were among the pioneers in this. This is what literature says. I have put the references at the end. And now NIV is considered an integral part of management of moderate to severe. He just pointed out with the whole study that how COPD patients were really weaned off that. Now, what happens in our cardiac surgery? We get patients who are having COPD, who are diabetic, who are obese. So that is what I was saying. Now that NIV is proved to be useful in COPD, so all the COPD patients undergoing cardiac surgery in our department are actively planned to be put on NIV, which is a good decision making, as he just told. Coming on to a bit of evidence which suggests that NIV is of benefit in other patient groups which physiotherapists manage, that is acute on chronic respiratory failure as well. Then weaning from mechanical ventilation, this is mostly our job, that sick patients, so many tough cardiac surgeries, long cardiac surgeries happen, and weaning from mechanical ventilation is one of the main aims of the physiotherapist and the whole team along. Then yes, one more, and selected patients with hypoxemic respiratory failure. This I will be talking somewhere else, because not all patients with hypoxemic respiratory failure will benefit from NIV theoretically, but some bi-level I'll tell next. So coming on to so I've tried to put my presentation with headings, like first I'll be talking about managing acute respiratory failure with NIV. Alright, so I'm not talking just in cardiac surgery. In cardiac surgery also we encounter this. Patient is extubated and lands up in respiratory failure. For us, it's a patient of acute respiratory failure. So the usual scene that we encounter is acute hypercapnic respiratory failure. That patient starts to retain CO2, pH starts to recede, and then he is the best candidate for an NIV. So what we do is, the order is, a decision is taken up that the patient is good enough to be used for NIV. I mean, NIV is set up to reduce the work of breathing, to promote a more advantageous pattern of breathing, improve gas exchange, and reduce the need for intubation. That is what he just talked about. Coming on to the problems which Sachin only pointed out right now, this is that managing the NIV, just the decision, or that offers so many difficult things in itself. And that is, if you can see here, I hope it is visible, because this doesn't usually happen in ICU anymore. This patient was there in CT5, in ward that NIV was put up, because usually what happens, since NIV is used so randomly, I mean so much in ICU, that we proactively put some dressing here on the nose, and which we usually avoid. But this patient last month that we saw, for Dr. Fozia was taking care of CT5. So this patient, we typically saw that she was managing the patient. This patient had hypercapnia only. But this mask fitting, he had low platelets also. He did land up in this leak and pressure areas. So which per se theoretically may not be counted as one of the major things to avoid NIV, but what happens is patient's acceptance to NIV has to come, and he has to breathe coordinate with the mask. It is not that sedated patient putting on a PRVC is to be say a little simpler. A patient doesn't have to do anything, but here the patient has to coordinate, and with such kind of a scar, this is a little of a problem. Coming on to other problems which are less likely but important, pneumothorax I have not yet encountered up till now, but pneumothorax is something that can happen anytime, anywhere. Last month in ICUA, there was one patient with tube. Somehow the pneumothorax came up, and nobody was like, you were discussing kahan se aa gaya hai. So pneumothorax is something can come from anywhere. But we have not encountered any patient having pneumothorax post NIV as such. But yes, abdominal distension, that gastric air that Sachin was pointing out, is something that we need to address. Then yes, coming on to the fact that secretion retention during NIV can be a major reason for failure of this technique in acute patients. This is what I want to emphasize, that once the decision of putting an NIV is done, but if in case, but proper physiotherapy or the techniques to remove the secretions are not taken up in acute patients, that only can bar and what the intention of putting the NIV is can be totally just negated. So that's why, just to overemphasize the need of physiotherapist. So coming on to the chest physiotherapy during NIV use, what we are supposed to do. So we have an array of techniques that we all learned. Most of us are physiotherapists here. Okay. So most of us are very clear about the airway clearance technique. In fact, not to mean only physiotherapists, everybody knows it. In the night, I see everybody doing physiotherapy. So all of us are all aware about all the airway clearance techniques that we all use up in ICUs. Breathing exercises, postural drainage, everything combined, because NIV offers one thing that patient is not intubated. So that tube thing is not bothering us. So we can put the patient in any postural drainage position that we wish to. Yes, the compromise that we have at our end is most of the patients are median sternotomy. So we just cannot put for 4 weeks even the prone positioning that you might find in the literature. But yes, every other thing is possible. So that's one good advantage of NIV. The decision of getting an NIV gives us the time to work actively on the patient, and if the patient is the right patient who has been taken up, who is cooperative, able to cope up with our techniques that we are telling and cooperate. So this is the best plan to go forward to. ACBT is one technique that mostly we use. First time I learned ACBT was with Dr. Gupta. He was, sir, this is something basically we use. And sir would really nicely give, vibrations. And we learned from him that ACBT, we all therapists are clear that it talks about breathing control, thoracic expansion, followed by forced expiratory technique. So where it helps to clear out the secretions. Then a study by Bellon and co-workers found a significant improvement in the amount of sputum expirated in those randomly assigned to use PEP therapy and assisted cuffing compared to those assigned to use assisted cuffing alone. As Dr. Sarvesh was pointing out, that literature is scanty. Because when I was trying to find out, so NIV with all those parameters of length of stay and hospital length of stay, yes, at the end of every study, they say little more studies required, more studies required. But then these are the studies that are amounting to prove that physiotherapy is needed. So just to put a case study, the same patient that we had in CT5, he was typically put on NIV for hypercapnia. I think few of us remember last month who all were in what Dr. Fozia was seeing, just because he was doubtful to have a COVID. So I intervened on the day because I was COVID positive prior to that, whatever. But Dr. Fozia was seeing this patient and was responsible for weaning this patient because he had multiple issues. What was not he having? He had a bad X-ray, right lower lumbar. I think Fozia, correct me in case I'm putting it wrong, because she was the one who was seeing the patient. Right lower lobe was consolidated. Hypercapnia, VBG, it was in CT5, so it was VBG that was being done, but that too, CO2 was beyond 90s. So anyways, this patient was really cooperative, platelets were low. So this patient was put on NIV, and every damn thing that a physiotherapist is supposed to do on such a patient was done. So we thought it was the best to click. So first picture reveals that the patient is on NIV and we are mobilizing. So routine 2 sitting positions. He was having secretion retention. So for this, with PEP therapy, Acapella, we all recognize. So he was earlier it was he was doing inspiratory spirometry. What happens in CTVS is the first line of thing is to start with spirometric exercises and routine exercises in chest physiotherapy. But if the chest, because what the time that we have with NIV patients is short for physiotherapy, like we plan okay with 2-hour physiotherapy or 4-hourly. So we plan that NIV is taken off accordingly. The bronchodilator or whatever regimen has to be given is given that time, followed by physiotherapy technique, and again the patient is put back on NIV, right? So for that time period, a chest physiotherapy is being done, and everything was being done for this patient. I hope this was successfully weaned and discharged from ward. I am not aware of the final outcome, so I'm not putting it up as a case study. Anyways, so what the evidence suggests is the total time required to wean the patients from NIV was significantly shorter in those who received PEP. That means if we are giving only routine PEP therapies, that is Acapella, for a short period of time and along with NIV, so the total time that we require to wean the patients is definitely shorter, which is also good outcome criteria, even if it is not affecting the total average length of the stay of the patient, but in a way, directly or indirectly, it is affecting. So results from these studies suggest that additional secretion clearance techniques, this is what I want to emphasize, are not only feasible, because he just said that we are going to put an NIV on a patient who can tolerate not being on NIV for few minutes. So that is why we are able to remove NIV, put on a bronchodilator, execute our PT techniques, and then put him back on NIV. But I'll tell you something different happens in Britain, and this is what goes on in our country. But anyways, this is not only feasible but also potentially valuable in reducing the time NIV is required in patients with acute respiratory failure. Now, this is another heading, in a way, post-operative patient management, which is mostly we do. In ICUs, in our department, we are handling only post-operative patients only. So we are using positioning, mobilization, breathing exercise to improve the lung volumes. We do for every patient. So and even an NIV patient needs that, which alters expiratory flows in post-operative patients. AIM is again the facilitation of removal of secretions and reducing atelectasis that we commonly find. This is a point that use of bi-level, that is BiPAP, in patients who developed hypoxemic respiratory failure following lung resection. There was a study that showed improved clinical outcomes with a significant reduction in the need for intubation and mortality rates compared to standard care that included chest physiotherapy. Because in hypoxemic respiratory failure, NIV is not the thing of choice, but one study said that bi-level support did help. So that is where earlier I pointed out that in selected cases of hypoxemic respiratory failure. So another study that looked at periodic bilevel use and compared this to periodic CPAP and incentive spirometry in patients following coronary artery bypass grafting, both reduce the degree of pulmonary restriction post-operatively compared to spirometer, but fewer patients treated with these two modalities developed mild or moderate atelectasis compared to the only spirometer group, that is 15% versus 30%. So the way we started our journey when we only use spirometry, then we grew up to using PEP therapies, all these are indications. So that was the primary indications, acute ones that we encounter in CTVS, but as sir also pointed out, chronic respiratory failure and NIV. That we know that for obstructive sleep apnea patients, this is a home remedial thing that they buy the machines and they use it for home purpose. So significant proportion of patients requiring domiciliary nocturnal ventilation will have a primarily neuromuscular diagnosis. Are we all okay on that? Right? So now while NIV offloads the inspiratory muscles, improves ventilation and sleep quality at night, problem of weak expiratory muscles with a poor cuff and reduced ability to clear secretion still remains. And this renders the individual susceptible to recurrent chest infections and pneumonias, which is a major cause of morbidity and mortality. So that is why in patients with respiratory muscle weakness, assessment of cuff effectiveness is necessary, for which you require a physiotherapist. And then it is important that these patients and their caregivers are provided with apt training from physiotherapists in the use of assisted cuff and airway clearance technique. Otherwise, we'll again land up in a failure. That despite the use of NIV, it happens OSA patients on yearly basis they have some bouts of pneumonia and they have hospitalizations for that. So this heading is NIV for patients in COPD. Precedingly, in the preceding presentation, it has been talked about. But for us in cardiac, again, I'm saying these days the use of NIV in our ICUs is growing up. Why so? Because in the patient profile is also changing. Earlier, when I joined this department 2 decades back, I think it was the age profile for CABG was 60 plus, but now we find 38-year-old patients post-COVID and undergoing CABG. Then so many COPD patients undergoing cardiac surgeries is kind of patient profile that we cater to. So that is where he said elective decision for an NIV. So these are the patients whose patient profile is already clear with us. We know it's an obese COPD patient. So we are all likely that while he's deciding for the extubation, already we are searching for the NIV mass and the availability issues that will be needing. So the studies at an RCT was done to evaluate the addition of domiciliary nasal ventilation to pulmonary rehabilitation. Basically, COPD patients are handled by pulmonary medicine people, and they are the ones who are prescribing. But they also found that NIV used for sleep augments the benefit of exercise training with significant improvements in exercise tolerance and quality of life compared to those patients receiving only exercise training. Pulmonary rehab as such we don't do here, but obviously this forms a part of our whole therapy regimen once our patient category is such that has undergone a cardiac surgery and is already a patient of COPD also. Here is where I wanted to point out that in Britain, exercise is part of physiotherapy management for patients on NIV, meaning thereby that we are mobilizing patients here, like that patient we pointed out. We would put off the NIV, put on oxygen, attach to an oxygen cylinder, and then mobilize in the ward, right? But in Britain, what they do is they use NIV along with the mobilization. Probably because what I found in their literature was they are using, this was a general thing, so not talking about cardiac surgery. So what they do is they use NIVs like our BiPAPs, a simple machine, which can be just held up and with the patient on the BiPAP support. So even if maybe they are using the clinical criteria that even when the patient cannot be weaned off NIV, they really put it on NIV and then mobilize the patient on that. This was a video of the patient. Would that play in PPT? This was just to show that the patient, that same patient was being mobilized in the ward, but जो भी है, then this, the thing was that we detached the NIV. Sorry that in video I could not cover the eyes. But what I wanted to show was that in India, this is our practice, be it in ICU, be it in wards. We are taking the oxygen cylinder and mobilizing the patient. So by the time patient is off NIV, this is the package of physiotherapy thing that we need to do, and this was done. So ultimately, concluding what the perspective of an physiotherapist towards NIV is that now that NIV is being increasingly accepted as first-line therapy in range of patients presenting with acute respiratory failure, the technique has already moved out from the ICU to the wards and to areas, if we talk about the pulmonary rehab part, at homes also. People are using NIV. I remember when first NIV we were using, somebody came over and asked, please batao, I mean, somebody in my relatives is using NIV at home and wants to know what the machine, how it can be used. So this is something we all encounter. So physiotherapists have become increasingly involved in caring for these patients requiring this therapy. And I believe, or everybody believes, that we are well placed to assist the management of patients using NIV, either implementing and following up patients or integrating other PT techniques with NIV to enhance both the acute and chronic care of patients with respiratory failure. So these are the references, 4th and 5th and 6th one, the ones wherein the 6-year-old girl, they put an intermittent positive pressure ventilation, because the idea of the physiotherapist was that the patient, that the therapists were using PEP therapy for some time. But when our PEP therapy, for say what the maximum we can introduce is for 4 to 5 times in a day. Yes.
So like in our ICU, most of the time we have pediatric patients having severe PH, and most of the time we resort to do nasal suction. In PH crisis, one of the causes, so much irritation can precipitate a PH crisis also. So is it evidence-based that we should do nasal suctioning to clear, or is it we should resort to some nasal decongestant drops and decongest the airway and reduce the secretion? So should we go ahead with the nasal suctioning in pediatrics?
Do you allow me to answer her first? It was a lengthy question. I'll answer you. Because yours is a simple PEP therapy that everyone wants to know. Acapella was introduced in our department sometimes back, and not all are aware of it. I would like to really emphasize on that one. 2, ma'am, we'll have a separate talk on pediatrics, though, by Dr. Umaid and Bunty. So you'll be answered that in detail. But what I want to share here is that yes, we pointed out that once we are applying NIV, so we are giving a positive pressure, but if already the patient is retaining the secretions, such patient with an NIV will not give you the outcome we are expecting and for which thought purpose we applied the NIV. Coming on to the specific patient profile which you are talking about, that is a pediatric patient. Yes, these are very, very, very tricky decisions, because in a PH patient, everybody's eyes are for the PH crisis, and a physiotherapist, yes, does happen that we need to, when we are a little over focused about retaining secretions, and we are not very happy if the patients, we are finding too many crabs, so let's clear it off. Yes, it's a very judgmental thing, and it's a critical decision making thing, and I think it's the whole team that decides. So many times it happens in NICU that the patient is at the verge of intubation, but a physiotherapist feels no, it's a thick plug that's bothering, and we must just work on it, and we can improve the patient suddenly, and which has happened also. But yes, we have been wrong also sometimes, because in a patient of PH crisis, even before helping the patient by removing the secretions, we might just land up in worsening his cardiac profile and the pH crisis. I think Mante will answer in detail on that. But what I would, what you wanted to point out, because this is something, a talk of discussion most of the time in NICU, because the therapist is focused on one thing and the intensivist wants to save, and obviously the team in a way wants to save the patient only. So yes, I would say in a PH patient, we would like to go PH patient. There are other strategies, like we have an array of strategies in physiotherapy, not just suction to remove the secretions. So we can put the patient, I would prefer personally, if such a patient is off, is little more than 4 weeks or somewhere, putting the patient prone and decongesting the patient with other methods, as you said, is the safest way to do. If at all needed, we do suction with high careful, like with the thinnest of the thinnest, like 6 size catheter, and that too we do a little of nasal clearance. We don't go little beyond to ignite a pH crisis. So I think we'll talk in detail over that later.
I would like to add on to it.
He can.
Even the retention of secretions in the nasal passages may create the discomfort, and discomfort is also one of the cause of pH crisis. So we should try to remove the secretions by any means.
Basically, from the logical end, agar yahan this is blocked, NIV won't be functional, won't be beneficial also. So if the nose passage is not clear, NIV is just putting air by pressure. So how will it go?
Not only nose, whole of the sinuses must be blocked due to intubation or infection. So that needs to be clear. Sometimes what happens is that we just keep on putting a catheter in the nostrils, and secretion will keep on continuing coming out from the catheter. So that needs to be addressed. So if the patient is having a severe pH, we should use a catheter of smaller size, as Ritika said. Second thing is that we can use the aspirator, nasal aspirator. It is a safe technique. You can teach the parents of a child to aspirate through the aspirator. So it is having a sucking effect of the secretions. Or else you can put a nasal drop in the patient's
that is what she was pointing out.
And second thing is that the small child are having low resistance as compared to adult in the nasal cavity. And third thing is that the child are having a high pharynx, so high larynx. So they are obligatory nose breathers. So their notes should be clear by whatever reason is there, so that they can breathe normally. Thank you.
So from adults to pediatrics, we'll soon be moving, and I think this topic needs yet more discussion, and you're still not happy with what all has been discussed fully. Please do.
So what we are essentially talking about is small children who are on pacemakers. That is the patient population. So it is expected they will be somewhere around 5 or 6 months old. And yes, severe pH, blocked nose, secretion needs to be taken out. They are obligate nasal peaks. What you can additionally do is, suppose you have an NIV patient 40% went FiO2, whatever support you are giving. It would be a wise idea to switch to it to 100% before you are going for nasal suction. In a calm and quiet patient, it won't be much of a problem. The problem will happen when you have a patient who is already irritable or agitated. And it is expected that once you put the suction catheter inside, to use a measure which will decrease the PA pressure before this supply, best and simplest would be increase the FiO2 to 100%. Give a bronchodilator, pulmonary dilator whose dose is coming around. Suppose you are doing a suction at 9 o'clock and you have a 10 o'clock phenoxypenicillin, sildenafil, dosentane due. Give it before or at the same time when you are doing. By that time your PA pressure will start rising. This effect, preferably IV, so that once you have done with it, not only the close will clear up, but your PA pressure will also be either borderline, slightly high, which the child will tolerate once you remove. But keeping in mind that if you are using a non-invasive ventilation and you have something obstructing it, not wisest of the idea to withhold suction. Better to do it at the same time giving anti-measures to prevent increasing.
Thank you, sir. This only proves that it's a team management work that works in ICU, not a single therapy works, or not a single person is able to handle a single patient. Coming on to what you are, Acapella devices that you must have seen in use in ICUs. Green color devices that you must have seen. There are two kinds that we are available in the market, like blue colored, which you must not have seen, because what we the plan here is, what we do is we first ask for a spirometer as a routine thing, since it's a bit costlier thing. And with the efforts of intensivists, I think for patients at AIIMS, they are still giving at an economical cost. But on an average, I think it's more than 2,000 or 2,500, when a spirometer costs only 500. And the kind of patient profile that we have, economics is of a major value. So once you see that a patient has been asked for an Acapella, that means positive expiratory pressure therapy is needed for that patient. When I see an Acapella with the patient, I presume that the patient has been already been checked, that he is the right candidate for it. Retention of secretion is something that for this patient, typically we showed you that we asked for Acapella also. Why? Because a limited amount of time, we are not asking Acapella for everybody. Retention of secretion is something that is common in our patients, most of our patients. Why? They are not breathing, they are shallow breathers, they have pain and everything. And even if they are respiratory optimized before surgery or not, this still becomes an issue for the first few days. So what happens, this therapy is simpler thing to do, which is actually a device for home use. In our country, still I do not see pulmonary people asking asthmatics to use Acapella, but when actually we have tried in our patients, like some of the staff of ICUA has this asthma. So I told her, you use Acapella for this thing, domiciliary use, and she has improved drastically on her asthmatic bouts which she was having yearly. What I want to point out here, if you want to know how to use physiotherapeutically, then what we do is, I wish I had the Acapella, but in case you have seen it, you must have seen there's a fan at the edge of it, and we are asking the patient to blow inside the Acapella instead of sucking in as we do in inspiratory spirometry. So basically it's a forced expiratory thing. What happens is, once the patient blows out, in this is what we are commanding कि इसको जोर से फूको 1 2 3 4, and there are resistance setters which you must have seen a physiotherapist setting. So if you see that, we can discuss in ICU also 0 1 2 3 plus minus. So when we start off, we start with the minimal dosing. It's like a resistance exercise. So when the patient blows, this pressure rotates that fan and then creates the coils inside, electromagnetic vibrations, which go and vibrate here in the central level. So the kind of effect that I want to give by percussing the patient, or anyways the idea is to remove the secretions or dislodge the secretions. So this is one safest strategy कि patient को pain है, it is sternotomy hai, and I have very less time, like in 20 minutes of an NIV patient, I want to do damn everything about for the physiotherapy. So I have to make him sit also, I have to make him walk also, I have to give a CPT procedure. So I want to use the best of the best techniques in the limited period of time. So that Acapella 10 bouts helps us drastically कि bronchodilator दिया, make him do Acapella, and then he coves it out. For me, that's a successful physiotherapeutic treatment on NIV, and then put back on NIV. That's it. So I think it's a very simpler device. We'll discuss sometimes in ICU, because that checking out how to put the resistor coil, and then subsequently we keep on improving on that. Anybody else? Any other? Thank you very much.
Thank you, Ruchika. Now, tea is waiting for every one of us. I think this is enough of the session. Now, here we take a break of 10 minutes for a quick tea, and we will come back here soon. See how NIV works and what are the limitations and what are the challenges we have in adult patients while we are using NIV. But now, when we are using NIV in a pediatric patients, it's totally a different scene. The issues are totally different. Whether is their anatomy, their respiratory anatomy, which is totally different from the adult's anatomy, the compliance. They are not many times pediatric patients. They are not very compliant because you can't teach them. You can't make them understand. Adults you can direct, you can guide, you can dictate. But to a pediatric patients, it is very difficult. So compliance is another issue. Anatomy is another issue, and also the interface is a big challenge to keep a child, composed, calm, and that interface to be in a place so that there is no leak or minimal leak. So all those challenges, all those things and limitations make use of NIV in pediatrics very difficult. It's not easy. Chances of failure becomes much more higher than adult patients. So to discuss all those issues, what are the challenges, how can we minimize them? Now we have a very distinguished speaker of our own, is Dr. Umed Singh. He is the assistant professor in the Department of CTVS and Intensive Care. Give us a big hand to Sir. Sir, please.
Good morning, everyone, and thank you to the Department of CTVS only, the physiotherapy unit, to conducting such a wonderful event in which we can exchange our idea. First of all, I would like to clear that I'm not going to deal with all the challenge. I'm just going to provide the overviews because this talk will be shared by three of us. Dr. Sachin will cover HFNC part, Dr. Vanti will take care of the another two modes. So I will give you an overview that how in pediatrics patient this modality is helpful. So these will be the objective of my talk. I will be covering under these subheadings: definition, physiology, NIV algorithm-based approach, sedation for chronic patient, chronic respiratory failure, how NIV is helpful, and how the NIV is being used as a research tool. Because as all we know that the research data are increasing gradually, and in last 5 years, the data increased in the number which didn't took place in the previous 35 years. So I will give some emphasis on the research tool as well. So coming to definition part, as the name suggests, it's a mechanical respiratory support without endotracheal intubation. So here we provide the pressure support or the continuous airway pressure we maintain with the interfaces without intubating the trachea. And all of us, we know that there are two modes of this continuous positive pressure. One is the continuous positive airway pressure, second one is the bilevel pressure, in which we use the different pressure support for the inspiration and expiration. So how this NIV become such a major hit and why it is preferred, especially in the pediatric patient? And the answer lies in because it's a very easy modality and it avoids the intubation related complications because not that much expertise are required, and it can be using in the vast, you can say, area of the practice. Like we can use start from the emergency department, we can use it for the transport purpose as well as in the ICU settings, and post-operative SD units as well we can use. So these are the clinical perspective, but where the evidence lies, how it becomes so important for the pediatric patients. So here from this landmark publication by Kamath and details in the Pediatrics 2011, for the patients starting from the labor room, or you can say the premature neonates, or in the early hours of their life when they are exposed to or they are prone to this RDS, and how after the entry of this NIV thing, if from this table we see that initially before 1950 hardly there was any treatment available for this respiratory distress syndrome of the neonates, and the mortality, no treatment was available, so survival was very less. Then the oxygen therapy came into picture, and in early 70s that is in 1971, they when the CPAP thing come into picture. Here we can see in this particular graph that how just with the help of the CPAP, the survival increased up to 70%. So for the resource limited countries or in the periphery settings, this simple modality is really very helpful to prevent this mortality and improving the clinical outcomes. So what is the physiology? How this modality works and improve the survival chances or the clinical outcomes so drastically. So if we go into physiological aspects or how it works, so first of all, the simply we can assume that applying this positive pressure to the airway, what happens? The pressure keep the airway wide split open in the both phase of the respiration, that's the inspiratory as well as the expiration. When the airways remain open in the inspiration, we know any sort of obstruction, it helps into the to reach the gas to the at the level of the alveoli, and when the airway remains open in the expiration, the reverse take place, that it facilitates the removal of the gas from the alveoli. And what happened at the low respiratory tract, i.e. at the level of alveolar level, it increases the functional residual capacity, and when this functional residual capacity comes above the our closing capacity, the gas exchange take place, which ultimately lead to in this decrease in the ventilation perfusion mismatch. And ultimately the effect of these two is it decreases the work of breathing as oxygenation of blood take place. So more oxygenated blood is supplied and the respiratory efforts come down, respiratory rate comes down, and the work of breathing comes down. For our subset of the patient, where one more slide I would like to discuss, that the NIV and cardiopulmonary interaction, because the patient subset we deal, they are almost have some sort of the cardiac dysfunction, either they have left ventricle, left side of the heart at compromise, or right side dysfunction. So in this scenario, what happen on the left side of the heart, how it helps in the improving the left ventricle function, it decreases preload and it decreases afterload. And simultaneously, by decreasing the work of breathing, it decreases it shunt the supply of the blood which is used in the, you can say, respiratory function to perfuse the rest of the body. So this is how it help on the left side of the heart. And contrary to this, on right side of the heart, the available evidence suggests that it, instead of helping, it has some negative effect on the right side of the heart, because it increases the afterload to the right ventricle as well as decreases the preload of the right ventricle. So the patient, subset of the patient which are having left ventricle failure, this NIV is really helpful in our pediatric population. So to simplify how to understand, to make it understand for all of us how this NIV thing work, because as by now we all of us are aware that it's a very important modality, and all of us should know that how it works. So these Qatar group of the people come with this algorithm. They published in 2019. That algorithm stands for acronyms AIIMS. So I stands for indication, C for contraindication, E for equipment, modes, and important part of the analysis of failure. And once we do this analysis, what should we do? Should we escalate our therapy, or we win the patient? So I would like to discuss one by one this algorithm. I state for the indications of NIV. So in general, the patient who are in respiratory distress, not the respiratory failure. First, we have to understand the difference between the distress and respiratory failure. So patient who are having distress, they are the appropriately managed with this NIV thing. Patient already landed up in the failure, definitely they are the candidate of the intubation. So that the respiratory failure can be of multiple type. In pediatrics, in general, they don't use the term, but for understanding purpose, we can say that type 1 respiratory failure, that is due to the hypoxic respiratory failure, where the NIV is indicated is the patient with mild to moderate ARDS. Second one is the acute pulmonary edema. And type 2 respiratory failure, that's the hypercapnic respiratory failure, which are the various obstructive lung disease, asthma, drug overdose or neuromuscular disease. All of the patients come into this category where the NIV is indicated. Third and important subset of the patients are the patients who are immunocompromised. In these patients, NIV helps in the way by avoiding the invasive ventilation. We can avoid the complication of the invasive ventilation and most commonly infection for this subset of the patient. So we can avoid the infection by managing the patient with the help of NIV only. And in our patients, it can be used as a weaning modality, which we commonly use. Further, we can divide our patient on this basis in two groups. First, the patient in them electively we wean on the NIV only. That we electively decide that okay, we will extubate this patient and put him on the NIV support. And second group of the patients are in which once the patient is start to land up into the distress, we put them on the NIV. So this is our subset of the patient where we use the NIV. And last one indication is the NIV for the palliative care. So the patient in which all of us, including the parents, know the outcome. In them, NIV can be used as a modality of maintaining the oxygenation into the terminal stage of the disease. C of the AIIMS is contraindication. So contraindication, we can divide them absolute, relative, and where we can use. Absolute contraindications are, suppose a patient is at the verge of arrest or already patient is require some sort of resuscitation. In those sort of the patient, instead of wasting time to give them NIV support, we directly go for the invasive ventilation. Patient who are having declining mental status, suppose patient the GCS is going down and below 8, definitely it's an indication for the intubation. And patient who requiring airway protection, suppose burns patient are there, patient who are having convulsion and having excessive respiratory secretions, in those group of the patient we can't use NIV. Patient having severe ARDS, in severe ARDS criteria are there when the PO to FiO2 ratio is more than 100, less than 100, then those are the group of the patient where directly we supposed to establish the invasive ventilation instead of wasting time in the NIV. And patient who are having airway trauma, craniofacial trauma, in those patient also it's an absolute contraindication for the NIV. In patient who are hemodynamically unstable and who are having upper GI bleeding or who have massive pneumothorax, in those it should be avoided. And in patients who have recently undergone the esophageal or gastric surgery, in those patients we can use NIV with the discussion of the operating team. So coming to the equipment part, that is the E of AIIMS algorithm. We can divide the equipment we use in the NIV in 3 main categories, that are the NIV interface and headgear, NIV ventilator, and NIV tubings. So there is a vast, you can say, development in this NIV interfaces, especially for the pediatric patients, starting from the helmet to the mask covering the full face, nasal pillows, mask which cover only the nose only, or oronasal mask. Simultaneously, the stripes to fix this mask or this interface are also different for they are also have changed from time to time. And most commonly nowadays what we use, the nasal prong, these are the most commonly used interfaces which can be used for the both as for the HFNC as well as for the bilevel ventilation as well. These are rhyme cannula which we more frequently or more commonly use in our day-to-day practice. Machine part, NIV ventilator, there are dedicated ventilator who deliver only this who are used for this NIV purpose only, or our conventional ventilator we can use them. They are also have inbuilt mode. With the help of them we can deliver all sort of the available modes of the ventilator with the conventional ventilators. Limbs, in limbs part, with the NIV ventilator we use this single limb circuit, but it have its disadvantage. The main disadvantage is it is the rebreathing, that's the retention of the CO2 is there. For that there are various mechanisms. For that they have pop-off leak valve as well as they have vent on the mask as well. And the most suitable circuits available in current day practice is this dual limb circuit, which we use with the conventional ventilator. Coming through the aim of the Iceman algorithm, these are the modes. So I will be discussing about the modes briefly, although they will be covered one by one separately in the upcoming talks. So most commonly used mode is this continuous positive airway pressure, where the inspiratory and expiratory pressures remain equal. That is set between the 4 to 8 centimeter of water. Synchronized inspiratory positive airway pressure ventilation, although it's very difficult to, and it is not also commonly practiced or not available in the United States, as you can see they have mentioned in this particular slide. But here what they try to do, they try to synchronize the inspiratory pressure, which is approximately of the value of 8 to 15 centimeter of water, and the expiratory pressure varies from the 4 to 8 centimeter of water. Nasal intermittent positive pressure ventilation is the same as the previous mode. Here there is no synchronization, and this is the mode we commonly use even in our day-to-day practice. Heat humidified high flow nasal cannula, as we know for the neonates, any flow above the 2 liter acts as a CPAP only. By replacing the gas from the nasopharynx, it creates some sort of positive pressure which help to transfer the pressure to the level of the alveoli and solve the purpose of this non-invasive positive pressure ventilation. These two are the advanced mode, in which the high frequency oscillatory ventilation and neurally adjusted ventilator assistance. These are the advanced mode, in which they said that in HFOV, the frequency by which they deliver the ventilation is 10 to 15 hertz per second, and they say that no synchronization required. And yet the neurally adjusted ventilator assistance, here what they do, they sense the diaphragmatic electrical activity. On the basis of that, they try to deliver the machine try to deliver the synchronized breath during the inspiration. So as we know, the maintenance part of the NIV, once we start the therapy, the area where we are taking care of should be have equipment, appropriate monitoring, repeated facility of the X-ray as well as the ABGA. And meanwhile, while we are taking care of the patient, we are supposed to be vigilant, and we are supposed to take care of the to prevent the failure. So what the algorithm suggests about what we supposed to do to analyze this failure thing? First of all is the clinical monitoring. Then we look for the complications. We monitor for the complications if there are any, and then certain predictors. We should be also be aware, or frequently keep checking that okay, the in which direction the therapy is going. Should we initiate the upscale or treatment early, or should we wait? So what sort of clinical monitoring we do? We look for the patient parameters, that after starting the therapy, either the patient is comfortable or not, work of breathing has been come down or not, and if we simultaneously look for the clinical parameters, how the heart rate of patient is doing, respiratory rate has been settled down or not, what is the SpO2 of the patient, or how overall the hemodynamics parameter of the patient are doing. Simultaneously, we look at the ventilator parameter, is leak is there or not, the tidal volume is the machine is delivering is the adequate or not, or the patient ventilator synchrony is maintained or not. And simultaneously in the, you can say, our newer ventilators, we can look for the various pressure loops or graphs that also give us idea that what sort of the ventilation is being delivered. If we look for the laboratory parameter, we check for the frequent ABG. In ABG we look for the pH. pH below 7.25 is a established marker that if we are not able to maintain the pH above than 7.25, it's time to go for the invasive ventilation. Simultaneously, same is for the PaCO2. If we are not able to bring down the PaCO2 below 65, then also it's an indication for the intubation. And we look for the PF or SF ratio. Although our patients we have different subset of the patients, so it's not implication for our patient, but they suggest that the SF ratio of Less than 160 is indicative of to go for the invasive ventilation. Here SF ratio is the what the SpO2 to the FiO2 ratio. In the settings where the ABG facility are not available, they can use at a surrogatory to the PF ratio to escalate the our therapy. So next is monitoring for the complications. So first of all, we look for the leakage. Leak compensation, various newer devices are available. They have good leak compensation, but still there is a gray zone that how much percentage of the leak can be allowed. There are few studies that we can allow the leak as much as by the time the adequate tidal volume is generated, we can allow the leak. If we are able to see the adequate pressure on the monitor and adequate tidal volume, we can allow the leak. But still they come with one study that up to 69% of the leak is we can accept up to 69% of the leakage. Till then there will be the oxygenation of the patient will be maintained good. After that we have to think about to adjust our you can say the interface what we are using or the other measures we can take. Most of time in the neonates and infants we are doing with the help of the this nasal CPAP. So in that scenario, the closing of the mouth anyhow by putting a strap or putting a pacifier and they have find that increases the pharyngeal pressure significantly. Second thing, we look for the asynchrony. So why the asynchrony occurs on the patient on the NIV? Why asynchrony occur? Because the oxygenation part of the patient is not taken care of properly. So in that scenario, patient either have restlessness or tachypnea. So in that to find out that the asynchrony can be either the inspiratory or expiratory. So first we have to find out what is the basic mechanism behind this asynchrony. So looking searching for that, either we review all the available monitors and data, and as well as we look for the leakage, and by manipulating our ventilatory setting for some extent we can decrease the asynchrony. How? By increasing this inspiratory rise time. If the leakage is high and the inspiratory rise time is more, then there is a possibility that more part of the what we are delivering is going to be leak. So in that scenario, we can by adjusting or by decreasing this inspiratory rise time little bit, we can reduce the asynchrony. This is for the inspiratory synchrony. Same happen for the expiratory asynchrony. So in that scenario, we do the reverse, and simultaneously we look for the other complications. What are those? Those are barotrauma, pneumothorax. They recommend that before starting the NIV therapy, we should do a chest X-ray to see for the baseline if there is any pneumothorax or not. Then the chances of aspiration or hemodynamic instability, these are the major complication. Minor complication may be present in the form of skin breakdown, nasal mucosal trauma, eye irritation or injury, or gastric distension. These can be prevented. Gastric distension can be prevented when we are using the either we have put the NG or not. By the putting NG and keeping it open, we can decrease this minor complication, and that increase over the success rate. So what are the predictors? Do we have some predictors in our hand that can help us that when is this the therapy is going to fail? So first of all, the hypoxia part. Here the SF ratio, which they do first, second, and 6 hourly. Then ABG parameter, as I previously discussed, that PS below 7.25 and PCO2 below 65 can predict the hypoxia. Work of breathing. If there is no improvement in the work of the breathing of the patient, then also we can predict that our therapy can be going to be fail. And the severity of the underlying disease. Suppose patient are having severe ARDS or pneumonia, in that patient the chances of failure are more. And age of the patient also they take as a predictive factor, that the chances of failure are more in the patient who are less than 6 months of age. And initially stage of at the patient's initial condition, that what was his the PRISM score or pre-operative, the time of the when we initiate the therapy, what was the basic diagnosis, and what was the hemodynamic condition of that patient at that particular time. We should also keep that in mind, that this patient might require the elevation of this respiratory therapy. So sedation, how sedation help in NIV? In fact, it is mentioned or advocated widely that the major advantage of NIV is that we require less sedation. So, and that ultimately lead into you can say lesser stay of the ICU, or early you can say shifting of the patient to the discharging the patient out of the hospital. But still there are studies who advocate use of this dexmedetomidine as a sedative, which also we also most commonly use, but it also comes with the complications, and the dose we 3 to 0.3 to 0.7 microgram per kg per hour dose we use, but sometime we face with this reduce in the heart rate and blood pressure in this patient. NIV in chronic respiratory failure. So the patients with the neuromuscular disorder and central hyperventilation syndrome, and the patient who have chronic lung disease who require ventilatory support, muscle rest, in those patients NIV can be used for months or years. And now they're coming with there is a vast literature available that home NIV support, for which they have proper you can say questionnaires, algorithms, as well as Weaning guidelines. All of my surprise in my search, I didn't find any guidelines to wean the patient from the NIV in our acute setting. But for the chronic respiratory failure setting, they have established guideline for these patients, that how they're supposed to wean the patient from the NIV. So how this NIV is helping, working as a research tool. The first, it was introduced in 1971. First publication came in the NEGM in 1971, and they simply show that the patient in which NIV was used, how the chest indwelling decrease, how the rate of the respiration decrease. Later on, they come with this impedance pneumography technique, where they measure the effect of this non-invasive ventilation. All the cohort was very small, in 20% only. They found with the help of this impedance pneumography that use of NIV, how improved the patient's breathing pattern and how overall outcome was improved. So here they use NIV along with this pneumatography. Later on, the literature came when they applied another non-invasive measuring technique. Like here they use the respiratory inductance plethysmography. So these all are the non-invasive monitors which are applied on the chest, and just with the help of them they find to measure the endpoint outcome. Here they try to measure with the help of this the change into the volume, respiratory volume, and for index it they divide it with the tidal volume, and they come to learn with the help of that they calculate the work of breathing, and they able to show that okay, that this was the work of breathing previously, this was after the set time point after the application of the NIV. So what next? How patients are, how recently they are, what they are looking for. So as we previously discussed, that it increases the FRC and it decreases the athletic segment and all, but how they are able to measure this thing in the real time. So what they are doing, they are applying the NIV or CPAP, and with the help of this impedance EIT, electrical impedance tomography, it's a newer equipment, simultaneously non-invasive equipment, they apply it on the chest, work on the principle of it, give some micro current and able to derive the picture of all the lung segments with the help of this equipment, and they're able to show in the real time that how after applying the NIV, these lung segments which are previously not taking part in the gas exchange, now they are opened up. So this is how they are doing such kind of the studies. So here we can see over the period of time the NIV is same, but either with the change of the mode, with the change of pressure, with the change of sedation, or with these non-invasive tools, they are able to produce or generate more and more data. So these are the, you can say, interventional or developmental studies. If we look for the availability of the descriptive studies, there are also there are so many literature is available that here also they try to establish this volume leak monitoring. They try to develop an algorithm, and with the help of that algorithm, were they able to measure that how much volume is leaked. So another, it's an interventional study. And if we come for the descriptive data, so they have done so vastly, they have managed the data so vastly that in the 31 PICUs across the United Kingdom and Ireland, for the 7 to 8 years, they have entered all the data, and they analyzed it, and they found that all the parameters they were measuring, increasing the including the mortality, they found that it reduces the mortality by 3.1%. So this is the data which support that how this mortality is going to be increased day by day. Use is going to be increased, as well as more and more research is going to come out. Simultaneously, if we compare the various technique, suppose the HFNC with this intermittent ventilation, there is also recent studies on this, which is published in our Indian Armed Journal, Armed Force Journal only. So these are the prototypes. There are vast literature available, and it's for sure that we are going to use this modality is being increase its use day by day in our daily practice. So thank you. Any questions?
Synchronize with that. In adults, we know that they
Yeah, that's a difficult part. But what they are saying that just after this, just keeping the pressure in appropriate limit. See, simultaneously, our aim is to prevent the discomfort. So there is a pressure range in which only it helps. And we come with this advanced version. They have is modes. Intermittent NIV ventilation, either with the conventional machine or as well as our NIV dedicated machine. They have modes. So they have divided spontaneous mode, time mode, and ST mode. So what they say in spontaneous mode, when patients they support the machine support patient's own breath. In time mode, it's like our controlled mode, either the pressure control or volume control mode, in which each we set the fixed rate, or either the flow cycled or time cycled, it deliver the set rate in the each minute. Or ST mode is like our SIMB mode only. So here we said that okay, these much mandatory breath will be delivered by the machine. So these are mode always available there. So it predicts the patient's respiratory efforts, inspiratory efforts, and according to that deliver. But still not all the breaths what we deliver not synchronize. What they believe that if we able to create the nasopharyngeal pressure what we are setting on the machine, that pressure transmit till the alveoli when airway is patent open, because patient is spontaneously ventilating. So if we are able to what we set, out of that suppose 70-80% of the breath in the breaths, the pressure is we are able to transmit the pressure till the alveoli, it's going to keep the alveoli open and able to deliver our gas till there. So this is the principle on which it works, and that's why role of all of us is very important. When to start and what we can do to synchronize the to decrease this patient ventilator interaction. And second thing, when to wean, that is also very important. Suppose sometime patient is crying, all the what we are delivering it's coming out from the mouth. So effectively nothing, we are not achieving much, or we are not able to deliver much, or you can say to the alveoli of the patient, but still patient is on NIV. So that's why we as of now how we win, and Dr. Banti will discuss if we and still most of time the winning is as I told now, that in acute setting there is no fixed guidelines to win, and in such patients more chances of the barotrauma or pneumothorax are there. Uh-huh.
can you show that slide where you showed all the masks for nasal for kids? all are from AIIMS, so we know, I think we have only one type with us.
No, we have nasal
We
pillow.
have only nasal.
No, no, no. Right now we have nasal mask with us. And
But we have not utilized this because of either
see, these are the helmet and full face mask. These are the something they use initially, but they are not as much user friendly.
they are not.
They are not.
Best ones are what we are using.
They are not user friendly. They are not user friendly. It is how what they use for the bubble oxygen, bubble CPAP and all. By you can say.
We are preferring using HFNC.
See, as of now, this is RAMS cannula, and it's not FDA approval. Although it's not FDA approval, and it's developed by our country only, from scientists from our country only, and around the globe. This is the most commonly used modality for the subset of the patient we are dealing with. In post-operative setting, immediate post-operative, where we use either for the neonates or infants, or for the pediatric population, this nasal pillow. Nasal pillow we have. Nasal mask. See, if we look for the stripes and all, it's more cumbersome. It's more cumbersome to apply, more cumbersome to maintain. This is how they, over the period of time, they evolved. Initially they use helmet, then full face mask. Now our target is to make patient more and more comfortable, more and more productive. When we come to see for the look for the literature, that what they are doing in the chronic respiratory support, chronic respiratory failure, what they are doing at the home. Then you will find that these are, you can say, they use in the combination with the toys, giraffe NIV and all those things. They will come to they're using the prong in this way. So now the practice is switching more and more towards the prong. Now nasal prongs. There are various sort of nasal prong available, and because these keep the mouth free to eat, causes less discomfort to the patient, and we can deliver the therapy for more prolonged period in the single setting. So these are, it's not about the equipment, it's about the how we use them, what is the technique, and it's really helpful.
So I would like to add on to it, as we have asked for the synchrony on the mechanical ventilator with the patient on NIV. So we have to look for the normal respiratory pattern of the patient. What is the patient's inspiratory time? What is expiratory time? And as per the time, normal time of the patient, we can set the NIV according to that. Because every single patient is having different inspiratory time and different expiratory time. So accordingly, we have to set the inspiratory time. One setting is there on non-invasive mechanical ventilator setting, and inspiration percentage. So you can increase or decrease that percentage so that patient may have a proper synchrony with the mechanical ventilator.
Any respiratory rate role?
Actually, on pressure support mode of NIV, there is no setting of respiratory rate. On pressure control mode of NIV, there is the setting of the respiratory rate. And one more thing I would like to add on to it. As we are treating the cardiac surgical patient, we are treating patient as a restrictive lung disease. So what will happen is that the patient, the small diameter airways are already infected. So resistance of their resistance is very high. So you always emphasize on keeping the inspiratory rise time to the higher side when you are predicting that the airways are narrow. Thank you.
Gastric distension prevention.
Yeah.
But again, it increases the leaks.
See, the leak is for the how much diameter of the nostril we cover. Now there are color coded this nasal prongs. So our target is to, and there are also interface to fix this and put on the nostrils, and on those interface we put this nasal prongs. So it's going through the nostril, and it's going to, you can say, the gauge what patient have, you can say, or gone to into the stomach. That part will come out. So it's not in the pharynx. Yeah, your concern is right. What they are doing in the study, they're putting this tube or any probe into this nasopharynx to measure the pressure, how they are changing. So in that scenario, there's some chances of the leak, but still they make this whole system the closed system. So our main emphasis is to cover the as much part of the nostrils as possible. That is according to the size of the nostril as well as the on the basis of the age of the patient, the color coded and this interface are available. Second thing, to keep the mouth closed. More emphasis they are giving the keeping the mouth closed. They have done the studies by putting the straps on the chin to keep the mouth closed, and they found that increase in the nasopharyngeal pressure is more in that scenario. So it's a very, you can say, simple thing. We are not supposed to go in very hi-fi and what is going on. Clinically, what we are doing on the floor, that is very, very important. Early picking the signs, it's improving or not, when to intervene. That is the very important part, and it's this is really, really helpful modality. What I am finding in our day-to-day practice.
Thank you, Dr. Umair. Now our next speaker is Dr. Bunty, our colleague. He will be addressing the practical issues when you are actually applying an IV in a pediatric population. So I welcome Dr. Bunty. This is
A very good afternoon to all the delegates and my colleagues, friends. Today we are here to discuss about the non-invasive mechanical ventilation in CTVS, neonates and pediatrics, application of NIV and physiotherapeutic intervention. So as discussed by Dr. Umaid, the various interfaces being used for the neonates and pediatrics, I will not go into detail of it. So right now we are using a cannula which is identical to the AIIMS cannula in our department. We have modified it. Ideally, this cannula is being used for the high flow oxygen therapy. It's an optiflow cannula. So we have modified it by connecting the terminal end of the cannula with the rubber connector of the O2 reservoir bag, that is anesthetist bag we use for the manual ventilation. Why we are using this particular cannula is very, very important. It is very well tolerated by the patient. It is very soft, so it will not irritate the nostrils of the pediatric group. First. Second, it is embedded with the non-collapsible spring inside the tubing. So this tubing will not get collapsed because it is embedded with the spring. So this is a technical detail about this particular cannula compared to the AIIMS nasal cannula. AIIMS nasal cannula may irritate the airway mucosa, mainly the nostrils. but it may not. That's why we are using it. So depending on the gestational age of the patient and actual age of the patient, there are different sizes of cannula we use, starting from red one up to the green one. So criteria to choose optimal size of cannula is very, very important. Why is it so? In various researches, it has been found that choosing a nasal cannula of optimal size with a positive pressure ventilation is going to deliver the positive pressure up to 60 to 70%. That's why choosing a nasal cannula of optimal size is very, very important for the patient. So as per the age, you can see approximate age range, gestational age, like for premature neonates, for neonates, full-term neonates, yellow can be used. For infants, purple can be used. And for the pediatric group, from 1 year to 6 years, green one can be used. So let us see the technique, how we should use the NIV or how we should apply the NIV. So I will show you the video. So first we have to secure the prongs inside the patient's nostril. Then we have to stick the nasal cannula over the patient's cheeks bilaterally, and we have to secure it with the clip. Now we have to connect it with the mechanical ventilator, and the mechanical ventilator is already been set. So after connecting the child to the mechanical ventilator, we have to look for the ventilator parameters and waveform. If it is satisfying, then we have to be satisfied with the vitals, whether the patient is comfortable with the breathe or not. So whenever you are putting a patient on NIV, you should always look at the monitor. So that patient should be, we have to ensure that the patient should be hemodynamically stable. So that is how we should approach with the NIV. So there are different settings we use in our CTVS department, especially for neonates and pediatrics. So start with, it is not conventionally being used nowadays, CPAP. Rather, we put the patient on pressure support POP mode, the pressure support mode or pressure control mode on NIV. But when we set on the CPAP mode, the PEEP should be kept at 6 to 8 centimeters of H2O at the start of the therapy as per the tolerance of the patient. Pressure PEEP at the rate of 6 to 8 centimeters of H2O, that means patient has to inhale, breathe in with the pressure support of 6 to 8 centimeters of H2O and has to exhale against the same pressure to maintain the patency of the airway. So sometimes it is very difficult for the child and child may get irritable. So compared to BiPAP, CPAP is not very well tolerable. It is shown in the studies, many studies. So CPAP is not being conventionally used. Then FiO2 should be set as per the requirement, metabolic requirement of the patient, and ideally should be kept at the minimum. Why is it so? Because if you give unnecessary oxygen to the patient, it may have toxic effects for the patient's systems. Then some ventilators are mounted with the trigger in it. Conventionally, the ventilators which we are using with NIV are not having a trigger set into it for NIV. For invasive ventilation, trigger is set, but non-invasive ventilation, trigger is not set. Ideally, the ventilator which we are using. So when in Drager's ventilator, the trigger has been set to 1 liters per minute at the start of the therapy. So this is a pictorial demonstration of how we should set the CPAP mode on a mechanical ventilator. So you can see in this particular picture, the pressure support of above PEEP is 0. If the pressure support of above PEEP is 0, that means it's a CPAP mode because PEEP has been set to 6 centimeters of H2. Fine. Then O2 concentration is set at 50% as per the requirement of the patient. As I have said earlier, the inspiratory rise time is very, very critical in deciding factor. And how we can decide it? As per your auscultatory findings. If the patients are getting fine creps or rhonchi or V's, you may predict that the patient may have a inflammation in the airway. So small diameter small diameter airways are not going to ventilate properly. Then you can increase the inspiratory rise time as per the requirement of the patient. What is inspiratory rise time? Is the time taken for the pressure to rise from the baseline up to the peak airway pressure. If the duration of pressure to rise from the baseline to the peak airway pressure is short, the airflow will be turbulent, not laminar. And turbulent airflow is irregular airflow. That is not going to ventilate the deeper tissues of the lungs. While as a laminar airflow is a regularized one, streamlined airflow. So that needs to be taken care of when you are setting the patient on the mechanical ventilator, especially in the non-invasive mechanical ventilation. As I have discussed earlier, end inspiration 30% of the breath cycle. So rest is a pause, 10% is pause ideally, and 60% is a expiratory phase, that is expiration. So the patient is already turned on to the Is to E ratio of 1:2. Ideally we keep at 1:1.5 to 1:2. So this setting has been backed with the backup ventilation. If the patient is unable to breathe in, then ventilator will automatically go into the backup mode of ventilation, and that breathe the patient will be supported with this number of breaths with this much of pressure control above PEEP and this much of inspiratory time. So pressure control above PEEP, that means patient breathe, when the patient is taking breathe, he is supported with 5 plus 6 because 5 is a pressure control above PEEP and 6 is a PEEP. That means patient's breathe is augmented with the total measurement of 11 centimeters of H2O with an inspiratory effort. Getting it? So this is how we should set the mechanical ventilator at the start of the therapy. While the pressure control above PEEP is, we should always try to keep the pressure control or pressure support to the minimum as per the requirement of the patient. And you can decide with the auscultative findings and the extra findings and ABG findings. And then and only you can titrate whether the patient requires increase in pressure support or pressure control as per the hemodynamic and metabolic requirement of the patient. Then we'll discuss on pressure control mode of non-invasive ventilation. The PPS is set at 4 centimeters of H2O. You can go maximum up to 8 to 10 centimeters of H2O. Pressure control above PEEP can be set at around 10 to 12 centimeters of H2O. Maximally, beyond that there will be a leak. There may be chances of leak because of resistance offered by the airways. Then trigger should be set at 1 liters per minute. Is to E ratio ideally should be kept at 1:1.5 to 1:2, and respiratory rate should be set as per the age of the patient. So this is a pictorial demonstration how we should set pressure control, non-invasive pressure control mode. The pressure control is above PEEP is set at 12 centimeters of H2O, respiratory rate 30, PEEP. This patient requires more PEEP as the airway is over collapsing as per auscultatory findings. So I have kept the PEEP at the higher side. Then O2 concentration, there was no requirement of increase O2 concentration. So I have kept at minimum 40%. Is to E ratio I have kept at 1:2, and inspiratory rise time I have kept at 20% of the 0.2 second.
So it is a time required for the baseline pressure to reach at the peak. So let's discuss about the pressure support mode. PEEP is kept at 4. Should be at the start of therapy. We should keep the PEEP at around 4 centimeters of H2O, and you can go maximum up to 8 to 10 centimeters of H2O. Then pressure support above PEEP, you can go up to 10 to 12 centimeters of H2O, and trigger should be set at 1 liter per minute, as some ventilator may have a trigger facility in it. So these are the settings, pictorial demonstration of pressure support. PS is 5, PEEP is 6, O2 concentration 50, inspiratory rise time is 0.5 second, 0.15 second, and inspiration 30%, and it is backed by the backup ventilation of respiratory rate of 30, pressure control over PEEP of 5, and inspiratory time of 0.5 seconds. There are some other devices which can be used, especially for the pediatric group. Ideally, what we do is for neonates, infants, and pediatric group up to the age of 2, we try to put them on nasal cannula, NIV through nasal cannula. The patients above that age, up to the age of 7, we try to put them on the BiPAP device with the help of ResMed Pisky mask. So this is a BiPAP device which we use. It is a single limb device which provides the inspiratory pressure and gaseous admixture. It is the mask, the Pisky mask, is having a vents in it, so that during exhalation the patient will exhale to the atmosphere, not into the BiPAP device. So this is a ideal ResMed Pixie mask we use. This is the nasal mask we use very commonly up to the age of 2 to 7 years of the age of the patient. And this ResMed device has to be used with the child above 13 kgs. If the weight of the child is below 13 kgs, you should not use this particular ResMed device. You can opt for a non-invasive mechanical ventilation through nasal cannula or some other devices. The weight of the child has to be above 13 kgs. So commonly used mask with the BiPAP are full face mask, nasal mask, oronasal mask, then nasal pillow can be used. So it can be used for a variety of lung conditions like restrictive, obstructive, normal lung conditions. Patients getting surgery, after surgery you can use. Then there are different modes, as Dr. Amuyad has also mentioned: spontaneous mode, spontaneous time mode, then pressure assist control mode, and intelligent volume assured pressure support mode. So initially at the start of the therapy, especially in the pediatric group, you always try to keep the IPAP 8 centimeters of H2. And what is IPAP? It is a summation of pressure support above PEEP as well as PEEP is a IPAP, and EPAP, expiratory positive airway pressure, is the actual PEEP. So terminology is different. EPAP is a PEEP only. So don't get confused. IPAP is a summation of pressure support over PEEP and PEEP. So respiratory rate should be set as per the age and requirement of the patient, that how much support is required. Some patient may not require support of number of breaths. They are triggering their own breath, so they may not require the setting of respiratory rate. So they can be put on the spontaneous mode. So after applying NIV, there is no halt of physiotherapy. We have to think beyond that how we can help the patient in a better manner. The actual work of physiotherapy after applying NIV is to take care that and make sure that patient should be off NIV as early as possible. So main purpose of physiotherapy after application of NIV is evacuation of inflammatory exudates and tracheobronchial secretions, removing airway obstruction, decreasing airway resistance, improving gaseous exchange, and diminishing work of breathing. All these are very, very important. So commonly used physiotherapeutic interventions in neonates and pediatrics with NIV in the CTVS department are positioning and mobilization, nebulization, humidification therapy, chest maneuvers like chest percussions and vibrations, naso-oropharyngeal suctions, and manual intermittent positive pressure ventilation. We have emerged with this. Earlier we were quite reluctant of using this manual intermittent positive pressure ventilation. Now we are using it very frequently. And if the patient is on a long-term mechanical ventilator and have phrenic no palsy, then we are using PNF. That is neurophysiological facilitation of respiration with a different therapeutic techniques. Dr. Altaf, I'm sure that Dr. Altaf will demonstrate you in a better manner in subsequent talks. So let's discuss on positioning. Body positioning refers to the application of positioning to optimize the oxygen transport by manipulating the effect of gravity on pulmonary and cardiovascular system. Gravity plays very important role to optimize the cardiopulmonary and cardiovascular functions. How is it so? Do we think that supine is a physiological position? I don't think so. Supine lying is not a physiological position. The care of the patient becomes easier in supine position, but it is a non-physiological position, I must say. So, propped up position or sitting position may help. How it is help? It enhances the pulmonary function as well as cardiovascular function. As far as pulmonary functions are concerned, it increases the functional residual capacity, increases the tidal volume, excursion of diaphragm, increases total lung volume, increases the anteroposterior diameter of the chest, increases vertical diameter of the chest, and as well as it increases the transverse diameter of the chest. So all lungs volumes and capacities get increased with the sitting up or propped up position. Apart from that, as far as cardiovascular response is concerned, it reduces the pulmonary vascular resistance and enhances the lymphatic drainage, and it reduces the central bed volume and pulmonary vascular congestion, and so pulmonary vascular resistance increases when we make the patient propped up. So all this needs to be considered when you are treating the patient, especially in the ICU, especially on NIV. It does matters a lot to the patient. The next position we more frequently use is side lying, primarily to reduce pressure over the weight bearing sides when the patient is on supine lying, to prevent the pressure sores. As far as physiotherapy is concerned, we are using this position for the purpose of postural drainage. But I must say, this position should be used very judiciously by the physiotherapist. As you are aware that the pediatric group, mainly the neonates, are having high chest wall compliance and lower lung compliance. By keeping this in mind, suppose for example, if the patient is having right lung collapse, so is seen in this particular picture. If for example you are putting a patient on right side postural drainage and left side of the chest is already compressed, it is weight bearing, so what will happen? The rib cage will get compressed, so resistance to the airflow on the left side will increase, and right lung is already collapsed. So what will happen? patient will be nowhere in the ventilation. The peripheral ventilation will not occur properly. So if the patient is desaturating, getting tachypneic, agitative, it is wise not to put patient in the sideline. Rather, we can put the patient in prone position. But again, I must say that prone position is ideal position. It improves the diaphragmatic excursion, increases functional residual capacity, reduces the airway resistance, and it enhances the mobilization of secretions from the peripheral airways towards the central airways. As well as it increases the lung compliance also. But this position may be deleterious if the patient is having sternotomy. And if there is a chances of dislodgement of chest tube or lines, then this position is deleterious. You can use this position if the patient requires it, and if it is a last resort on NIV and patient is at the verge of intubation, reintubation, then you can use this position with NIV also. Those patients who are having a thoracotomy, you can use this position very wisely. So there is no complication with the thoracotomy patients. But with the sternotomy patient, you can use it very wisely, or after 4 weeks of surgery. If the patient is not able to cope prone line position and all the lines and chest tubes are open, better to mobilize the patient with or without NIV. So mobilization and exercise refers to the application of progressive exercises to elicit pulmonary and cardiovascular responses to enhance oxygen transport. So what are the progressive exercise for the particular patient? For critically sick patient who are very sick, hemodynamically unstable, even turning the patient in a sideline position for a back care is a mobilization, because even turning a patient on the side may affect his hemodynamic, is a mobilization for the patient. For some patient, moving in the bed itself or bassinet itself is a mobilization. For some patient, moving at the edge of the bed is a mobilization. For some patient, moving out of the bed on the chair is a mobilization. For some patient, ambulation is a mobilization. So mobilization is a very broad term in context of cardiopulmonary physiotherapy, I must say. So let us see how we should mobilize the patient and how we are mobilizing the patient in that way. In this particular video, the child is moving its upper limb. Any activity, either it's playing, crying, patient is moving his limb, is a mobilization for the patient, that particular patient. So I want to discuss with you the one of the most important technique to further enhance the recruitment of the airways, increase the elastic recoil of the lungs, mobilize the secretions from the peripheral airways towards the central airways, improvement in the overall ventilation of the patient, thereby improvement in the oxygenation. That is a manual, non-invasive, intermittent positive pressure ventilation. So how we can use this technique? So I have applied a silicone mask for the patient's nose and by sealing the patient's nose and mouth,
10 seconds.
and I'm observing the patient's inspiratory effort. I'm just observing the patient's diaphragmatic movement, the abdomen raise, and with that, by sensing that abdomen raise, I'm pushing the air in, or I'm just inflating the patient's chest by squeezing the bag. So that will create the positive pressure ventilation in the patient's airways. So when we are putting the patient on an NIV and the patient still is having lung collapses and retention of secretion, then you can use this technique along with the purpose of increasing lung compliance and improve the peripheral ventilation. So it has to be, the consensus technique is giving a tidal volume 1.5 times more than the normal tidal volume during inspiration, which is then followed by the inspiratory hold of 1 second or 2 seconds depending on the age of the patient, which is then followed by the sudden release of bag by maintaining the PEEP. The sudden release of bag will increase the expiratory flow rate, and with that increase in expiratory flow rate, the secretion from the peripheral airways will drain towards the central airways. So it is related to the cough mechanism also. What happens in cough? We inhale deeply, let the air go beyond the site of impaction of secretions, and then sudden contraction of diaphragm muscle enhances the expiratory flow rate. So it tends to mimic cough in case of pediatric group. As I've discussed earlier also, the good chest physiotherapy has to be complemented with the good nebulization therapy. So there are variety of drugs which can be used, which includes bronchodilators like salbutamol, levosalbutamol, salmeterol, anticholinergics like ipratropium bromide we are using. It blocks the muscarinic receptors situated in bronchial smooth muscles. Corticosteroids. Corticosteroids, why? Because the patient may have inflammatory changes in the airway and may have airway edema. So reduce the airway resistance, you can use these drugs. May have airway mucosal edema. Mucolytics, again, it is going to narrow the airway. So mucolytics can be used. If the mucus is the cause of narrowing of the airways, then mucolytics can be used. And immediately, preferably immediately after the extubation, if the patient hemodynamics is permitting and the patient has stridor, we should use adrenaline because it's a instant bronchodilator and local vasoconstrictor, and it reduces the airway mucosal edema. So that's why we keep on using adrenaline immediately after extubation if the hemodynamics of the patient permits us. And now you must be aware how we are applying chest percussions and vibrations. Everybody must be aware that how we should do. So I will not discuss it in detail. Next is the oropharyngeal suction. Dr. Meera was asking about the airway suction. In severe PH patient, first thing is that we should use catheter size, optimal catheter size. Second is that we should use negative vacuum optimally with the patient. And third point is that we should use the, what I said? Forgot. Huh? Yeah, duration of suction should be less. In patient with a severe PH, we should use a duration of around 5 to 10 seconds. You have to complete the procedure of suction within 5 to 10 seconds. Then there should be not any alteration in the hemodynamics of the patient. Patient may not land into PA crisis. So let us see how we should do oropharyngeal suction. I have not kept the technique of nasopharyngeal suction in the video. Even I don't like doing nasal suction. So the whole procedure is being completed within 6 seconds. And to how much extent the catheter should be inserted should be monitored. It should be you should just approximately measure the length of the catheter by measuring it from the angle of mouth, right angle of mouth to the base of the ear lobule, and approximately that much of length you can put the catheter. So you will ensure that the catheter will remain in the oropharynx, so that the secretions, whatever secretions are there, patient may cough out, and that can be aspirated with the suction catheter. Again, I must say that the negative pressure should be kept at, in preterm neonates, the negative vacuum should be kept at minus 60 mm of Hg, and for the older childs it can go up to minus 100 mm of Hg, and for adolescent minus 120 millimeter of Hg you can use. So all this, after application of all this therapy, I have not included the PNF therapy. I think Dr. Altaf will take it in a better manner than me. Then coming to the weaning part, I have gone through many researches and I have given the references at the end. So oxygen requirement and weaning are often decided by clinical examination investigations, like respiratory rate. Patient should have good respiratory rate or acceptable respiratory rate. The work of breathing should be less. Then presence of retraction, subcostal, intercostal, external retraction should be less. Oxygen saturation should be acceptable, 95 to 100%. On auscultation finding, you will be able to hear a good vesicular sound on the peripheral areas. Then you can wean the patient. You may wean the patient from the NIV. You can think of weaning the patient from the NIV. So all this comes, all should come into the consideration when you are planning to wean the patient from NIV. So is the ABG analysis. If the patient ABG analysis is satisfying as per the metabolic need of the patient, then you can wean the patient from NIV. And last one is the CX3 finding. On CXR, if you find that the lungs are clear, then you can wean the patient from NIV. That's all from my side. Thank you so much. Any questions regarding to NIV? Yes.
In one of the slides, you said that there is a correlation between the weight and the masks.
Yeah.
What is that correlation?
Weight, age.
Age. 13 kg.
Yeah. No, actually, it is recommended by the company actually, who has made it. It is recommended by the company.
Specific reason?
Yeah, specific reason. Because, you know, the flow with which the BiPAP ventilates is more. It is not conducive for the neonates and pediatric group of age, of weight less than 30 kilogram. Because, you know, with increasing age, the flow requirement of the gaseous admixture is higher. If the neonates are there, the flow of gaseous admixture will be kept at around 5 liters per minute. For the older age patient, maybe 10 liters per minute. So it increases. So compressor is not designed in that manner. So yeah, so that may cause rather barotrauma to the patient.
It is basically
Yeah.
for the flow purpose.
Yeah.
Avoid the trauma.
Barotrauma also. And patient will not be able to tolerate that much of flow basically. So again, it is going to increase the what? Flow is more, it will create the positive pressure. If the flow is more, it will again create the positive pressure. The chances of barotrauma is very high. Thank you.
There is also a bypass. It is not very sophisticated. It has a little lesser parameters. You can't check it. You can't check in that how much is the tracking volume generated, what is the leak. So this is basically kind of a very basic machine. Good for the patient for whom you
developed initially.
or also to sleep apnea.
Now the new generation machines have bring more parameters into it, the more flow generation, classification of the respiratory rate, synchronization. That was the initial machine when it was developed.
Also, I want to add to your question. Like what is the reason why it is not used in less than 13 kgs of the patient? Is because that machine is not designed to detect smaller flows, smaller leaks. When the patient's weight is 13 kg and less, the tidal volume is less. So a small fraction of the leak will be too much for a child, and that machine is not designed to detect that. So yes, so even so that is why they don't recommend. So otherwise those machines above 13 kgs, they have some mechanism, they have an algorithm to compensate for the leakage. So which is not functional when the weight becomes less and the tidal volume becomes less. So the small leakage which can be detrimental for a small baby, and it may not be detected by the machine, it will be missed. So the patient will not get proper pressure and proper ventilation. So that is why they don't recommend. So I think so far we have talked a lot about
So I had a lot of discussion with Dr. Sachin regarding application of NIV or HFNC, which is best. And we had a lot of agreement and disagreement, and ultimately with that agreement and disagreement, it is the good thing about that is that we come to conclusion, a positive conclusion out of it. So let's discuss about the NIV versus HFNC. Welcome, Dr. Sachin.
So my talk is designed around, like, so much has been talked about. Today we have been talking about NIV, CPAP, BiPAP, and their positive effects. So primarily I will be focusing how NIV functions, how NIV works. So the idea behind how it causes the effect that we have been talking about, and that is why we have been using the NIV. So this is good for building up the concept. No, this is conceptualization of the NIV use. So that is the idea behind this talk. And later on, in last slides, I will be discussing how it is different from HFNC and what are the case scenarios where HFNC is more useful than NIV or the BiPAP. See how NIV helps a diseased lung. First thing, the NIV helps a diseased lung is by improving the oxygenation. Another thing is ventilation. So there are three main ways by which NIV can improve the oxygenation. So NIV increases the delivery of FiO2. So definitely, as compared to the normal oxygen delivery through the mask or through the nasal cannula, NIV ensures the increased FiO2. Second thing is reduced entrainment of the room air. What is happening with the conventional use of ordinary like a mask or nasal cannula? So whenever the patient is in respiratory distress, he tends to breathe more. His flow rate increases, the demand of the flow becomes much more. So there is a loose fitting of these interfaces. So a lot of air gets entrapped. But with the NIV, what happens is there is a tight fitting around the face, around the nose. So this entrapment is not possible. So dilution is not possible. So whatever FiO2 is there, we ensure a better way. We can ensure the better FiO2 with the use of the NIV interfaces. NIV also improves the ventilation perfusion mismatch. How it is? Let's see one by one. See, as I said, these mechanical ventilators, these NIV ventilators and the interface, they allow an increased and more accurate delivery as compared to the traditional oxygen mask. So we can ensure the FiO2. And also this reduces the entrainment. See the oxygen mask which is loose fit or the nasal cannula where there is a scope of entering lot of room air, lot of mixing can happen. So which is not possible when you are using a tight fitting NIV mask. And how the NIV improves ventilation, perfusion ratio? See, there is a lot of atelectatic lung. Lung is disease, it has a lot of atelectasis. So these atelectatic lung which is not expanding with the pressure, when there is a driving pressure, the NIV has a driving pressure, positive pressure, it causes the expansion, it causes the opening of these alveoli. So what happens, the areas of the alveoli which were better perfused, now better perfused than before, right? So these lungs which are the collapse, the perfusion is there but ventilation wasn't there. So NIV, the effect of NIV is transmitted to those alveoli. Alveoli are now opened up. So those perfused alveoli now are taking part in ventilation also. So there is an increase in VQ ratio. So there is a better oxygenation. The again has been given at the alveolar level. You can see in the first picture, the lung capillaries are in the alveoli are passing through it. They are not distended, not expanded. So later on when the NIV is there, so that way the NIV can be used in hypoxic respiratory failures. Or as Dr. Umid has also mentioned, you don't wait for the failure to set in. Actually, where you are anticipating that the patient is getting desaturated and there is a anticipation of hypoxic respiratory failure. So NIV has a role there. And how? By improving the oxygenation. So there are 3 mechanisms by which you can improve the oxygenation. So the next use of NIV is, how the NIV is helping is through ventilation. Let's see what happens. So either one of the 2 key ways where the NIV can change the ventilation, can improve. See, definitely we have seen in the studies with the NIV, there is a minute ventilation which becomes improved. So since NIV is a spontaneous mode, you can't control the rate. So if the minute ventilation has to get better, it is the effect on tidal volume only. So NIV either improves the tidal volume in the patients who are doing a rapid shallow breathing, their lungs are not expanded, or the patients, other side of patients are there where there is an airway trapping, the lungs are hyperinflated. So in both scenarios, the NIV is going to help in improving the ventilation. So how does it help? See, the driving pressure, the distending pressure acts as a distending pressure. This gives some force, some positive pressure which augments. So the tidal volume initially, when the pressure, see the in first picture, the inspiratory pressure is less. The moment is like a ballooning effect. The moment you put the more air with some pressure, the balloon will expand. The same effect is transmitted to the alveoli. So the tidal volume will increase. So how NIV counteracts the intrinsic PEEP? There is intrinsic PEEP. What is intrinsic PEEP? It is the pressure which is being exerted by the airways at the end of expiration. So there are some disease conditions where there is already a narrowing like COPD and there is a hyperinflation of the lungs. So alveoli are hyperinflated. So but these hyperinflated alveoli, they are not taking part in ventilation. So there is not actually enough gas exchange happening at that level. So how does this NIV help? It helps in extending, or it helps in countering that intrinsic pressure. So the constrictions become less. So the alveoli which were hyperinflated, they didn't have the time to relax. They didn't have a time to relax. Why? Because because of the intrinsic PEEP, before the expiration, which is a passive process, could expire the whole air out of it, the airways has already constricted. So but when the NIV is in the picture, the NIV, the pressure is delivered to it, it keeps the airways open. So there is enough time for the gas to escape. So that is why the hyperinflation is countered. So in both ways, where there is a rapid shallow breathing, the tidal volume is less, then it can also help. And where there is already an airway inflation, hyperinflation is there, the NIV can also help. So now we can conceptualize how we can use this NIV in different settings, like rapid shallow breathing when this tidal volume is less, when you have to increase the FRC, especially in the post-op patients who have pain and other things, they're not breathing well, then IV can help. And also the other settings where like acute COPD patients. So those patients like who have a inflation of the airways and there is an airway trapping. So apart from improving this oxygenation and ventilation, NIV, these effect changes the respiratory physiology. So as a side effect. So how does the respiratory physiology, how does these improved oxygenation and ventilation affect the respiratory physiology? So there are three ways in which NIV can influence it. First thing is, when we are using NIV, FRC get increased. Also, there is an improved lung compliance, and it also helps in removing the lung water. How does it happen? Let's see it one by one. See, NIV, how can it improve the FRC? What is FRC? It is the functional residual capacity. That means when we have expired, there is some amount of air is always left in that. So since when I am expiring at the atmosphere, so there is more of the air is passing out, right? So atmospheric pressure is less, so I can expire more. But now when I'm expiring against positive pressure, which has been delivered by the NIV, my breath will cease early. So I will not be able to expire the whole air out of it. So there will be more air left inside the lung. So that is why how this FRC is improved, right? So this FRC, what it does, this FRC helps in recruiting the alveoli which were collapsed earlier. Improved lung compliance. So this is the another effect on respiratory physiology. Like the compliance of the lungs comes into the steep region. The S of the curve, when the FRC is increased, you see the low FRC when the lung is atelectatic, you see the curve is at the bottom. Curve is at the bottom where you have to apply too much of pressure just to gain a little bit of tidal volume. So that pressure can be detrimental. So if you are doing that, that means you are getting prone to cause barotrauma. So, but if the FRC is good, when you look at the middle portion, when the FRC is good, that is called the ideal condition, where even a small change of pressure can bring about the large change in the tidal volume. So when you are able to maintain the FRC, so that means you are able to improve the respiratory physiology. That means there is a less chances of barotrauma with it. Even a small change in pressure, you can achieve a large tidal volume. So the idea is not to give too much of pressure also. Why? Because if you are delivering too much of pressure, positive pressure, the lungs will be, alveoli will be hyperdistended. Again, the graph will come on the plateau region, where you have to put another high pressures for a small change in tidal volume. So FRC is maintained. This is the another effect of NIV pressure. And now we see how NIV removes lung water. Imagine a situation of cardiogenic pulmonary edema. What happens? ये point. Let's see this. The first picture here. Okay, thank you. See this first image here. This is the alveoli, right? And this is the interstitium, and there is the capillary. So the distance is too much. Distance is too much for the gas to travel for a diffusion. So when NIV is placed, it has opened up the alveoli, and also it has redistributed the fluid to the neighboring interstitium. So what happens is now this diffusion distance has become less. So this is a very well proven effect. So that is why the CPAP has too much of success in cardiogenic pulmonary edema patients. Even in the morning, Dr. Sarvesh was mentioning this. CPAP, most of the studies you will see on the CPAP, it is extremely helpful, especially in a patients where there is a non-infarction, when there is no EMI patient, non-myocardial infarction patients. So in such cardiogenic pulmonary patients who are primarily because of the heart failure pathology, and this works like wonders. And also we have an option, we can use BiPAP also and CPAP also. That I will discuss in the uses, when to use BiPAP and when to use the CPAP, which will work more better. Yes, yeah, this is done. So this was I have discussed this effect on respiratory physiology, how this happens, how this NIV works. Now, apart from the benefits on oxygenation, ventilation, and improved respiratory physiology, NIV does changes to the lung cavity, the chest cavity. So this rib cage, this chest cavity has an effect on cardiac functions, cardiopulmonary functions. So cardiovascular functions are also get affected. As Dr. Umaid shown a very beautiful slide in the morning, that NIV is reducing a preload and NIV is decreasing an afterload. So I will be just a little bit elaborating on more on that, so that some conceptual building happens here, so that we can use and apply to the same concept as NIV. So what is preload? Preload is the right RV and diastolic pressure of the RV. So there are a few things about the preload. When the venous return increases, preload also increases. And there is a variation of with the respiratory cycle. Normally, when we are respiring, our preload is changing. This is called respiratory variation. So preload depends upon whether the patient is spontaneously breathing, in the sense when the patient is negative pressure breathing, or the preload depends also upon when the patient is put on mechanical ventilator. That means patient is put on positive pressure breathing. So let's see how NIV helps in reducing the preload. See, this is the picture when negative pressure breathing. So the picture 1, you can see this is almost the end of the expiration, and now the picture 2 here. As we start inspiring, the pressure drops. So there is a negative pressure generated, right? So the negative pressure is generated. It allows more of the venous return to come to the heart, return to the heart. See here, this arrow, negative pressure has generated, venous return has come to the heart. So more volume to the RV. So that is increased diastolic and diastolic pressure. So in normal, when we are negatively breathing, when we are spontaneously breathing, it's a negative pressure breathing. So when with this mechanism, RV load increases. So now we are putting the NIV. So what happens next? You see the figure 1 is almost the end of the expiration. The same thing, the patient starts inspiring, some negative pressure is building up inside the chest, the more volume is coming up. But since this negative pressure is countered, by the positive pressure, right? Positive pressure of NIV. Earlier, the negative pressure was developed against the atmospheric pressure. So now the negative pressure is not developed that negative, because there is already a positive pressure which we have applied from outside. So there will be a decrease in the venous return. So when the venous return decreases, so will be the RV load and diastolic pressure of the RV will decrease. Preload will decrease when we are putting NIV. So what is the clinical significance? How it is important in a practical patients and how it is clinically significant? See, when you are applying an IV to a patient who is hypervolemic, that means the patient, consider a patient who is in pulmonary edema. So decreasing a venous return will always be a helpful thing. So such a patient, when it is put to an IV, it will help improvement. It will show the improved pulmonary function. But examine on the other hand a situation when a patient is hypovolemic. Consider a patient who is status asthmaticus, who is hyperventilating, and who is on hypovolemic insensible volume loss due to tachypnea. Putting such a patient on NIV is not a very good choice at that time, right? So this is something we have to consider. So what is now, how does the NIV affect left ventricle? So NIV decreases afterload also. How NIV is going to decrease the afterload? Let's see. So what is the afterload? Afterload is that pressure which the LV has to generate to open the aortic valve. No, that is the pressure which is have to generate to pass the blood through the systole, right? So an increase in intrathoracic pressure will increase the afterload. How this is going to happen? Let's see it. So there is also a normal respiratory variation. This is a picture when we are negative pressure breathing. You see, this is the almost the before inspiration, at the end of the expiration. At the end of the inspiration, there is a negative pressure generated. See, so there is a pressure is given inside this. Almost 1 to 2 mm of Hg of negative pressure generally is generated, right? And almost 90 mm of Hg of the pressure is required to open the aortic valve in a normal situation. So a normal healthy heart has to work against two things. One thing is the negative pressure, that is around 1 to 2 mm of Hg because of the respiratory variation, and other thing is the 90 mm of Hg of pressure which is required to open up the aortic valve. So when the heart is healthy, this is not a task. This is quite easy. But imagine a situation when heart is not healthy. So what will happen then? See, look here. So now this is the negative pressure and heart is weak. He is not able to generate the pressure. So there will be pulmonary edema. So this is the blue line is indicating that pulmonary edema. The pressure is, the weakened heart is getting too much of the load on that. So again, you can see what happens then. The patient, in an anticipation, the patient will have spontaneously will take a large deep breath. When he will feel suffocated. He will take another deep breath, more negative pressure. So more negative pressure. So this will add on. The heart has to work now more. So again, a vicious cycle sets in. See, heart is not able to pump again, and there is a more negative. See, this pressure is dropping here. This becomes more negative, and there is a vicious cycle sets in. Heart is not able to pump against that. So there is again pulmonary edema will again setting and further increase. So how NIV can help? How can we use NIV in such a setting? So NIV helps in breaking the cycle. Let's compare the two pictures. Let's see this figure here, where heart was not able to pump against the negative pressure of around 1 to 2 mm of Hg and also the 90 mm of Hg which was needed to open the aortic valve. So now let's move ahead and let's see here. We have applied the positive pressure here. So heart is still weak, right? But that extra work which the heart was doing to counter that negative pressure is not there. So somehow the weakened heart would be able to move the blood through. So that is how NIV is helping, you see. So the afterload has been decreased, right? So heart afterload has been decreased. So this is the same concept which we use in many situations. I will come on to that also. What are the conditions where we can use and help the patients to use of the NIV, right? So now in this situation, you see when NIV is in the place, the weakened heart doesn't have to work so hard. Now the blood can flow. So this is a kind of assistance given to the LV, right? So you can see also now LV is contracting and delivering more. This LV compliance has become better. LV compliance has become better. So this is how it can improve the compliance. So it allows, the use of NIV allows a greater stroke volume and a better contractility. So how does afterload has an effect? How does it help? So it will reduce ongoing vicious cycle of cardiogenic pulmonary edema. So it will not let that set in, it will break that cycle, right? And it can also help in maintaining the status quo if the patient is not worsening, or it can prevent the intubation if it is at the beginning. But yes, one should not wait enough for the failure to set in or pulmonary edema to become much worse. So where ultimately the intubation is the last resort. So this is about how, what are the various conditions where we can use, and what are the concepts behind the use of NIV in those situations, right? Apart from the hypercapnic COPD patients, where the use of NIV is like a bread and butter. So of lately, last 1 decade or so, there is a new entrant called HFNC, or nasal high flow. The use of HFNC has got a lot of traction in past 5 to 10 years time. So many a times this new entrant has been clubbed with the NIV, but it is not actually the NIV. It is quite different from NIV. And most of the researchers and clinicians have kept it separate from NIV. So I will try to see what are the differences and what are the similarities between the two and how does it work. What is HFNC? HFNC is a high flow nasal cannula. It works on a very powerful blender. See, generally in an ordinary nasal cannula, it works around like 4 to 6. Maximum is around like 6 liters of the oxygen we can deliver. But when the patient is hypoxic, he is air hungry. He needs a flow very, very high. Flow that high, almost like 20 to 60 liters. The demand is so high. So that ordinary cannula cannot provide that much of flow. If we increase that flow, it cannot provide. The flow which is through the cannula is intolerable. The patient cannot tolerate that flow. So, but this HFNC cannula, the advantage is that you can deliver very high flow, right? So you can counter the air hunger very effectively. And also these blenders, these HFNC machines, they have that capacity to titrate among the FiO2 also. You can deliver 100% FiO2 through this HFNC machine and a flow like 20 to 60 liters. So this is very good for hypoxia, to counter the hypoxia, right? On the other hand, we have seen NIV was very, very good for hypercapnia, type 2 respiratory failure. So this is what are the parameters of HFNC. HFNC, you can titrate the FiO2 from 20 to 100%. It can give to a very high flow. It can be up to 20 liters to the 60 liters per minute. And you can always have heated and humidified air. So how does it work? What are the benefits? So how does it work? What are the proposed benefits? See, there is one biggest advantage is there is a precise oxygen delivery. So any hypoxic patient, HFNC is a good choice. Otherwise, the hypoxia where there is no loss of lung volume. So the patient is just hypoxic and there is enough tidal volume he is generating, then the choice can be the HFNC. So it also enhances functional residual capacity like NIV, but it is not very effective if you compare it with NIV, but definitely better when you compare it with plain oxygen mask or nasal cannula. It also helps in washing out the dead space. Let's see how this happens. You see, there is this is the nasal cannula which we use. So this is a loose fitting, and here HFNC is also not very tight fit. But when the patient becomes hungry and he wants more air in, there is a limitation to the flow here, but there is unlimited flow, right? So there is a chance of mixing and treatment of the room air, but here there is no chance. Why? Because the machine itself is giving the flow more than what the patient is demanding. So there is no mixing. So it works the same way, but different mechanism. So FRC, see, there are many studies which are being done. So definitely as compared to the nasal cannula, with the HFNC, the FRC increases by 25%. But it is not, the effect on FRC is not as much as with the CPAP or BiPAP. But also there is a discrepancy in HFNC. When the patient opens the mouth, this effect is not there. This effect is lost. So there was many research. The people have measured the oropharynx pressure, and they come to the conclusion, even whatever the situation is with the HFNC, there is an increase of 25% of FRC. So there is some effect, some positive pressure effect with HFNC, not as high or as good as an IV, but definitely much more better than simple plain cannula. Dead space washout. See, since there is a constant flow, high constant flow, so generally this space is always filled with high concentration of oxygen or whatever FiO2 we have said. So this dead space is washout. So there is always an air available here in oxygenation. So this dead space is not there with HFNC. So now we have discussed HFNC and CPAP and NIV. Let's see how they are alike. See, both reduces the entrenchment from the room air, and they both allow for the precise amount of FiO2 to be delivered. And both require some specialized kind of an interface, which sits on the rose or large bore. Even there are specific NIV mask and CPAP mask. There is also a specific NIV interface. That is a spiral thing, which Bunty shows. It was specifically for HFNC use. There was one spiral. This can handle a large amount of pressure and flow. It will not collapse on high pressure. And the good thing is, patient will tolerate it very comfortably. And they both can provide support for hypoxia. When there is a respiratory failure due to hypoxia, they both can provide the support. So now, how does NIV HFNC differ? See, HFNC provides less ventilatory support because it cannot distend the alveoli as a BiPAP can do. So when there is a pulmonary edema, so I think CPAP is a better choice rather than HFNC. Or also, we set a flow rate when we are instituting HFNC, and we set inspiratory and expiratory pressures when we are instituting BiPAP. That is another difference. And also this last point is pressure produced from HFNC is flow rate is lower as compared to the NIV. So we have discussed the mechanism and the physiology behind the use. So you can choose. Now you know how the BiPAP is going to act and how it is going to act on RV and how it is going to act on this LV. For example, like a patient where you need pulmonary augmentation of venous return we require in certain conditions like PH, where we do high oxygen therapy and we augment venous return. So at that time, we have to keep the pressures low because it can decrease the preload. So there are other situations like this. So what are the groups where this HFNC may not work? See, use of HMCP should be avoided in the patients like COPD, acute exacerbation of COPD patients, because there is a lot of airway trapping there, right? So BiPAP in such patients works more because they keep the airway distended and there is a proper gas exchange. Ventilation is like, because CPAP is a good mode of improving oxygenation as well as ventilation. Ventilation means change of oxygen to the carbon dioxide. So this is and also there are research available which says like this HFNC, when the patient is on vasoactive like vasopressors or inotropes, HFNC is not very successful. So this is some of those research articles I've just shared here for the reference. So as I said, ventilatory failure and hypercapnia, where you should use HFNC with caution or should not use, there is no absolute contraindication, no article was there which has absolutely denied, but definitely CPAP or NIV will work more better than in these patients. So now I summarize. This is the summarized the similarities and the differences of HFNC and NIV. Right? Thank you. Any questions?
In this ventilatory failure, you mean that HFNC patient is not cannot cope up?
No. Actually, when we have to choose between HFNC or CPAP, right?
That means we tried the patient putting on HFNC, he's not accepting, so we move on to NIV. This kind of ventilatory.
No. The initial choice. What is my initial choice? Ventilatory failure, especially when there is no gas exchange happening.
Prior to this, patient is breathing on room air, and then
Yes.
then you should not go for it.
Yes. If you're yes.
Thank you for a very elaborate presentation comparing the two. Can you specifically tell in CTVS patients what are the specific contraindications and precautions for both, like for HFNC and for same point which you have put on slide?
Actually, there is no research as per pertaining, which I have been seen through so many articles, where they have compared this, what you're asking, to the normal population or other population with the CTVS population.
Like, if they have any dysfunction or they're not producing any, output at all, or there's poor output. So, if you give NIV, should we give HFNC?
Yeah, if you're asking this question, there are a lot of material, lot of research is there where cardiogenic pulmonary edema patients, where heart failure patients who have a poor LV functions have done a lot better, where they have prevented intubation quite successfully. So these articles are enormous.
Type of surgery also, like if you have cyanotic heart disease cases, extensive exploration, do we have to
See, these conditions are not pathology based. Anybody, any patient, cyanotic, acyanotic, can land up in heart failure. It is not like that the patient is cyanotic or acyanotic, he may have heart failure or he may not have heart failure, right? So this is not condition specific. Pulmonary cardiogenic edema is not condition specific. Like it will happen to a cyanotic patient, it cannot happen to a acyanotic patient. It's not like that.
Can I take the for right or RV dysfunction we may use HFNC, LV dysfunction we may use
No, never. You cannot come to this kind of a conclusion. That is an erroneous conclusion.
Then LV dysfunction NIV is helpful.
See, HFNC is helping in both ways. See, there are, for example, a pH. How you treat a pH? You augment venous return, you give oxygen therapy, right? So where in such patient, the use of high pressures of NIV can be a little tricky, right? But a patient who is already hypervolemic, like pulmonary cardiogenic edema, where this CPAP works like wonders.
In a way, if we can we say HFNC is in between NIV and
No. You're going in a wrong direction.
See, Balaji, what I can understand and what I learn in 2-3 days in literature research, HFNC used in cardiac adult patient is not indicated or not there is any study, or also we are not doing it in our practice as well. But in pediatric patient, the flow required here is 20 to 60 liter per minute. So it's a dedicated equipment. In fact, we don't have in our
Setups, yes.
And pediatric patient, this flow of 2 to 8 liter, because they have smaller airway and requirement and lung capacity and all. So 2 to 8 liter is considered equal to this HFNC only, provided that air must be, the mixture of the gas must be humidified and heated. Okay, so pediatric we can use HFNC, but in adult HFNC where come into picture, and where the in this COVID situation now, when there are lungs are very fragile, they are in the end stage of ARDS, when the lungs are really fragile, and subset of the patient where the HFNC did wonder was the subset of the patient, to them we avoid the mechanical ventilation. Out of that the evidence created now. And what was the wrong with those people putting on the mechanical ventilation? In such, you can say, damaged lung, as soon as we start giving positive pressure ventilation, it will cause barotrauma, pneumothorax and all. We have seen in the trauma center very much. But okay, as soon as we give, so CPAP was not working for them. So that's why this HFNC thing came into practice there. Because it was it was giving the adequate, you can say, FiO2, right? It was making it sure that adequate FiO2 should be reached at the level of alveoli. And some washing should also take place. What Dr. Sachin mentioned, that after reducing this dead space and all. So it was helpful really. So don't think in that way that okay, right heart failure we can use HFNC and all those things. You don't know what's the real advantage of this in the adult cardiac patient. In pediatric cardiac patient, it's self-explanatory that we are providing some sort of, it's 4 to 8. All the time we are giving emphasis on what? The pressure should be as low as possible. So the nasopharyngeal pressure should be kept like 4 to 8, the recommend everywhere. So we try to keep it 4 5 as low as possible. If 4 or 5 pressure is transmitted to the level of alveoli, it's enough to keep the airway patent and to make sure that the airway, the mixture of the gas will be reached up to there. So it's very clear. And the pressure part, also the right heart failure patient, we don't keep them for the prolonged time. But most of time it's a mix, you can say, ventricular failure. Most of time we are dealing with this left ventricular failure only. Then people give us more challenge.
And the more advantage come from where? Putting the patient on the NIV, making the patient comfortable and decreasing the rate, which in turn lead to decrease in the work of breathing, because they are having very low ejection fraction, like 15, 20, 25% of the ejection fraction post switch patient, or the, you can say, very severe IV dysfunction patient. So their most of the cardiac output, because it's a reflex, more less and less oxygenation is there, it will be reached to the brain center, and more patient respiratory effort will increase. So rate will increase. So this increased rate will demand more cardiac output. Already patient is on the 20, let's say 20% cardiac output. More of it will be switched to the respiratory muscle. So over a period of time, the patient will end up into the multi-organ failure. You can say your output will go down, BP will come down, patient will be more irritated, more agitated, because there is no supply to the brain. So to cut down this, decrease this respiratory rate, to decrease this work of breathing, this NIV thing is doing wonder. We are seeing it in our daily best practice. So patient selection is very important. And meanwhile, our second failure treatment, like what we are treating with inotropes or various failure drugs we have with us, that are working. So at one point of time, we are able to separate them from the NIV. So these are the subset. Either we just put them on the electively on the NIV after separating from the ventricular ventilation, or we are seeing some signs that okay, this patient is not doing well, the rate is increasing. Over a period of time, the fatigue will set in, and the patient will end up into the respiratory failure. So those are the patient. And sir, as per you ask cyanotic or acyanotic patient, so it's about supporting the respiratory mechanism. Most of time, sir, please sit down. Most of time, what in acyanotic patient, what happens? It's the right heart which is compromised. Suppose in the ICR, most of time we found that the right ventricular dysfunction is there. For any palliative sort of surgery we do, like it's the Sun, Klein, or Fontan, in all those things, this positive pressure ventilation is not going to help much, because we are going to put more stress on the already compromised right side of the function. Either it's a passive circuit or decrease the right ventricular patient with the right ventricular dysfunction. So these are mainly these modalities. As I also mentioned in my presentation, that right side heart, there is a literature or there is a evidence supporting that it should not be used. So mainly these are the left side failure patient in which this NIV thing really work wonders. And what sir is telling repeatedly,
It's the same thing.
he has explained very well. The patient who are landing in the card in this pulmonary edema, and that is most of time left ventricular dysfunction, and most of time it's left ventricular diastolic dysfunction. So due to this mismatch in the preload and afterload. So as soon as we give him some positive pressure support, FiO2 increases, oxygenation increases, simultaneously diuresis increases. That will be added by supplementation of the IV Lasix as well. So this really helps. But our target is we should know that okay, this is the patient, this is the right time. We should not miss that time point that when to initiate this therapy. That is the most crucial thing. And early pickup. Okay, when to terminate this therapy, when to switch, when to wean, or either switch to the higher modality. That is the important. That should be the take-home message. Thank you.
So one more thing I would like to add to this is, like as sir has said, when the patient is in pulmonogenic cardiogenic edema, our idea how to prevent the barotrauma. See, you should not expose that lung to too much of variation of pressures. Like there should not be much of the difference in EPAP and BiPAP. In fact, the studies and the research and what the practice is, they don't use BiPAP in such patients. They use CPAP only. CPAP at a low pressure like 5, 6, 8, and you can titrate that. And do not expose such a lung. Already alveoli are flooded. So if you expose to EPAP and BiPAP, variation of the pressures, there is a distension, and then recoil is there, you can cause more barotrauma. So that is why you find more studies with the CPAP and very successful. But there is also a subset of the patients where BiPAP has been used, and they were primarily when pulmonogenic cardiogenic edema was accompanied by hypercapnia. When there is a CO2 retention and there is pulmonary cardiac edema, only then think of using BiPAP. If there is only pulmonary cardiac edema, no CO2 retention, PaCO2 is still within the limits, stick to the CPAP. So that will be a very safe strategy, because BiPAP, already a flooded lung, you are exposing it to the variation of the large variation of the pressure, it is going to cause barrel trauma further. So that is how we conceptualize and use the NIV. Thank you, sir. Now, see, we have talked about use and effects and benefits. Now, how to wean? So we are not talking it today, but definitely before weaning, we have to assess diaphragmatic function and the muscle strength. So how can we do it? So I welcome my dear friend Altaf. So please just elaborate on that.
So very good afternoon to all of you. My dear seniors, colleagues, juniors, and especially sir, Dr. Vishwa sir, with whom I have started the journey of working with ventilators in back 2002. We started I started with my master's thesis with sir in CABG patients. The point of mentioning this here is just to see the or explain the progress in our equipments. How can I change the slide? Okay, this one. Yep, open. Yep. So it's very important actually when a patient is on a ventilator or whenever the patient is in ICU. So the most important part of patient management, to be more precise and effective patient management, is to monitor the patient. Not only his hemodynamics, but his respiratory parameters too. So it has been since the beginning, mostly what is concentrated in ICUs is hemodynamics. But what is equally important is the respiratory mechanics, pulmonary mechanics. So majorly, if you see, diaphragmatic dysfunction is a major concern in mechanically ventilated patients. And majority of the studies say around 40% of the ICU patients are mechanically ventilated, out of which around 20 to 25% of the patients may experience delayed weaning, or they have some sort of difficulty in weaning. All of us know that mechanical ventilation per se is not a treatment. It is just a bridge towards the treatment. Basically, it gives you a time to treat the underlying cause for which the patient was mechanically ventilated. And although it is life-saving, but it has got a lot of deleterious effects, especially on the respiratory muscle function. So the most important reason for a difficult weaning or prolonged ventilation has been found out to be diaphragmatic dysfunction associated with the ventilation, which is classically called as VIDD. This is just because of inactivity or unloading of diaphragm. See, I'll go later about the pathophysiology of this. Diaphragmatic function, to be more precise, strength and the thickness, evaluation is very, very important, not only in effective patient management, but also to guide the mechanical ventilation strategies. Earlier, since around 5-10 years down the line, it always used the settings of the mechanical ventilator always were based on the airway pressure measurements. But the recent one, which has been recommended is pleural pressure measurements. And all of us know that pleural pressure measurements are not easy, and it's invasive to measure pleural pressures. So there are many research, I have put some references also, which have found out that measuring the esophageal pressures can give a good surrogate of pleural pressures, and this has been successfully used in the past too. So if you see, when you monitor the respiratory mechanics, it's basically transpulmonary pressures and transdiaphragmatic pressures. Now, if you have esophageal pressures, you can easily calculate the transpulmonary pressure and transdiaphragmatic pressures. The easiest way, I can say the gold standard method for measuring this esophageal pressures in the past was either by electrically or magnetically stimulate the phrenic nerves and evaluate the pressure generating capacity of the diaphragm, which is otherwise the strength of diaphragm. Most commonly used catheters are air-filled catheters, and there are 2-3 different types of catheters which has been successfully used. But the latest one I have come across is an adult catheter by Cooper Surgicals USA, and I have used it myself also. So the second important and the latest one is the ultrasound imaging of diaphragm, preferably the right hemidiaphragm, just because of its accessibility and the it's not overlaid by other organs also. It has been found out that the adult hemidiaphragm thickness is around 0.22 to 0.28 centimeters, this was a recent study by Vishwanath et al., and he has given us the normal average values. And in mechanically ventilated patients, we have found out that the thickness less than 0.2 centimeters is basically the end point below which we can say the patient has diaphragmatic dysfunction. So let us do some literature review. All of us know this. So this was a study by Pola et al., wherein he had done a cadaveric research, and he has found out some of the changes that it contributes around 72% of the tidal volume. So I can say that around 3/4 of the total tidal volume is just because diaphragm. That is why it becomes more so important in assessing the strength and thickness of this diaphragm. It constitutes both slow and fast twitch fibers, around 50% roughly. So I've explained you that there was a study by Spenskis, and he found out in his cases around 55% of his ICU patients had diaphragmatic dysfunction, some of which have at the beginning, and some of them have developed in 24 hours of mechanical ventilation. And he could find out that the two important causes of this diaphragm dysfunction was disuse and infection. He has found out with the course of time, patient on mechanical ventilation, thickness and strength decreases, and strength, which was twitch transdiaphragmatic pressures, as less than 10 centimeters of water, has a poor outcome to V. So a reduction of reduction of around 10 to 41% has been documented in many of the studies. If you see, once a patient develops diaphragmatic dysfunction, ventilator-induced diaphragmatic dysfunction, so the histologically you can see that inflammatory cells increase, macrophages, neutrophils, all these increase. The basic pathogenesis is like there is increase in proteolysis. So due to some pathways, activation of some pathways, wherein ultimately ubiquitin, nuclear factors, and calpains get increase in the body, and they are proteolytic agents. The oxidative stress, which has been documented by 4-hydroxy O'Neill alanine, and autophagy and proteasomal protein degradation has been found. Disuse of diaphragm, risk factors associated were found out to be age, the annual decline of 0.8 to 2.7 centimeters in maximum inspiratory pressure has been found after 65 years of age till 85. Duration of mechanical ventilation, if the patient is on controlled mode of ventilation for longer duration, there are larger changes in diaphragmatic function. And that is the reason why the advent and the newer choice is lung protection ventilation strategies like volume controlled ventilation or pressure regulated volume control strategies. The basic idea is to improve alveolar recruitment, improve the gas exchange and homogeneity in the lung fields, decrease the lung injury in ARDS patients, It facilitates the lung recruitment and ventilation perfusion matching. And if feasible, it should be always tried that the patient should be put on partially assisted modes, except in ARDS patients wherein we need that the patient respiratory system or the lung or the muscles has to be completely rested. Nutrition also plays a very important role. That's why, from the morning we had been hearing it is all the team effort. So it's not only one factor which contributes to worsening of the patient or improvement in the patient. So it's all together which matters. So that is why I tried to highlight it here. So keeping in mind the age of patient is very important. The nutritional and metabolic state of the patient is equally important. And we have found out the malnutrition of around 30 to 60% of the ICU patients because of improper nutritional status. So that can lead to increased catabolic hormones like glucagon, adrenaline, and cortisol. Inhibition of these anabolic hormones like insulin and testosterone has also been found out, and these all can result in decreased muscle mass strength and immune response. So other comorbidities like patient had sepsis, diabetes mellitus, hypertension, acute MI, diaphragm dysfunction associated. And to be more precise, when you talk about cardiac patients, CTVS patients, one of the common, this one is phrenic nerve injuries, wherein you can have, which is commonly because of cold hypothermia. Majority it's because of cold hypothermia. So in those cases, you need to be very, very, very vigilant because their phrenic nerves involved, so your respiratory, your diaphragm is already compromised. So serious illnesses wherein you need large amount of sedatives like this one, and the patient is in metabolic alkalosis, the outcome is not good, and your respiratory muscles are prone to get more and more weak. So it is always that you need to keep in mind that as less as sedation as possible to be encouraged. Glucocorticoids and neuromuscular blocking agents, which are commonly used in ICU patients, they also have a deleterious effect. So they can cause weaning delays. In case of it has been found out that they are associated with increased need of tracheostomies. So when you need tracheostomy, when you expect that the duration of mechanical ventilation is more. So they also inhibit protein synthesis. And I've told you, one of the biggest drawback is of diaphragmatic dysfunction is proteolysis. So if the patient already has proteolysis, and these glucocorticoids can, further aggravate the condition. So neuromuscular blocking agents like prolonged desaturation and reintubations can be this one. This is in nutshell, if you see infections, immobility, mechanical ventilation, this is the pathway. If you see, ultimately they can lead to respiratory muscle dysfunction. Now, most commonly, in the beginning only, when I mentioned that we started in 2002, so remembers that we had ventilators that time, Siemens, I think Servo 300, isn't it? So we worked with them. So they're still there. So we worked with them, and then the newer ventilator came 300A, which was having an auto mode facility. So why I'm discussing it here is, so not every facility will be having latest ventilators wherein you can have. There are newer ventilators which has come like Tima Horace, Tima Extend, which has recently come. They have this one that you can measure their transpulmonary pressures. But in this one, Siemens 300 or Tima Horace, they don't have that facility. C2, they don't have this facility. So you have to manually, give an inspiratory pause or expiratory pause to measure intrinsic PEEP or extrinsic PEEP. So there are a lot many things what from the ventilators you can have an objective assessment of whatever you are doing. So pressure measurements, basically we all know that all the muscles have two functions, either to generate force. In case of lungs, what we say, it's like to have a pressure change, or when it shortens, so it is nothing but a volume change. So it's in nutshell what we say, it is just the compliance. Okay, so measurement is basically by pressure transducers and it has been found out that air-filled catheters are more suitable for adult population, and water-filled catheters are more suitable for pediatric population. So, most commonly used are the air-filled catheters. They are very helpful in monitoring or recording your esophageal pressures and gastric pressures. Thus, you can have a transpulmonary and transdiaphragmatic pressure calculations. There was a very interesting study by Talmody, and it was recently. There were two versions of it, and he has found out that it is always good to have a ventilatory parameter selection on the basis of transpulmonary pressures, rather than relying on the airway airway pressures. So this balloon is a simple this one, but only thing is not every facility will have these catheters available. So all facilities wherein this catheter is available can utilize it, and this is a latex balloon, and distal end of this is having a balloon tip which transmits the pressure. It's around 5 to 10 centimeters long and 3.5 to 5 centimeters in perimeter. This catheter, I've just show you at the end how it looks. So this is how you measure the transdiaphragmatic pressure. You measure the gastric pressure. You pull the catheter around 10 centimeters. When the tip of the adult esophageal catheter reaches the lower end of the this one esophagus, wherein it is found out anatomically, it's presumed that the alveoli of the is directly connected to the lower third of this one. So the pressure changes in the alveolar space are definitely reflected there in the lower third of the this one esophagus. So these gastric pressures and esophageal pressures, they're not very easy, because when you want to have a this one pleural pressure measurement, there's only one crude way, that you go to the intercostal space, put a tube there, put a transducer, which is not possible in all the cases, except in trauma cases where you have a pneumothorax and the patient is put an ICD, wherein you can put a catheter. But in cases wherein it becomes an invasive procedure, so this can be of help, because this is non-invasive and this is a very reliable indirect technique which can be helpful in measuring the diaphragm pressure. Again, there are many studies which have validated the esophageal pressures as a good and reliable surrogate of pleural pressure. Direct measurement, I told you, is very, very difficult. So it was in basically 1847. It was Ludwig who has found out first time the pleural pressures, but it was in 90s wherein it became popular by Aaron et al. So successfully it has been used since then, and I have come across at least 10-15 studies, but I have not come across a single study in India or in Asian countries wherein they have used it for respiratory care purposes. So this is something like transpulmonary pressures. So you can do PEEP adjustments according to the transpulmonary pressure what you get. So this esophageal pressures can guide you to better outcomes like PaO2 and FiO2 ratios. Third thing is very important is diaphragm thickness, and the advent of use of ultrasonography in intensive care units have changed the scenario of management of ICU patients. So this is very widely used now and very reliable and valid measurement of even assessing or predicting the weaning success, or to assess the respiratory effort, or to detect the dysfunction or paralysis of diaphragm. So it was Waite et al. In 1989 who first have used the diaphragm ultrasound in mechanically ventilated patient to predict the weaning outcome. So this is the topmost one is the adult esophageal balloon catheter. This is made by Cooper Surgicals, and there are two more catheters by Brent, and one is by one company from UK. So this is what we have utilized. We have done a study in this. So we have utilized normal transducers. Normally, when you measure these pressures, so in other lab settings and all, you have big units like HRM units, which is as good as 5 feet, 6 feet high and 6 feet taller. So we have tried to measure them with transducer, which we routinely use for CVP measurements. And we have tried to stimulate, and this is how it is done. We have tried to stimulate on the posterior border of sternocleidomastoid. We have put two small electrodes, and bilaterally we have stimulated the diaphragm, checked it, and this one we have done an ultrasound simultaneously and found out there with the twitch. So we found the thickness of that diaphragm with the twitch, and this is how you measure the thickness as well as the pressure. So this is what Sonosite Turbo we used. The frequency is around 7 to 14 megahertz, which we have used. This is how you measure the strength by this. You have to use it, and it's not difficult to use. In our center, trauma center, we have used, it is as good as you put an NG tube. Similar way, it has a marking in centimeters. Similar way, it is put under aseptic conditions. So you put it, you measure a distance from nostril to trachea of your air, measure the distance, and then accordingly you put it inside, and then confirm the position. So how you confirm the position? Once the catheter is in place, it's in abdomen, you have found out it has crossed the esophagus, you just put some pressure on the abdomen and see the pressure deflections. So if there are pressure deflections, so you know that the placement is right. So confirm the placement. Basically, I've told you that these are air-filled catheters, so you have to instill 1 ml of air into the balloon, so that once you keep one thing constant, when you say we are seeing the pressure and volume changes, so we keep a fixed volume, then only we'll measure the change in the pressure. So you have to confirm the position, and then you have to attach to the one other end of this one catheter towards the transducer. This is how the recording comes. If you see the thing in blue, that is the average. So you can see esophageal as well as gastric pressures. So you can minus the esophageal pressure from the gastric pressures. That is what your diaphragmatic pressures are. So this is how you check diaphragmatic thickness. If you see here, it is this diaphragmatic thickness. The right side of hemidiaphragm is chosen for, this is called a zone of opponents. So this is between 8 and 10 intercostal rib, between anterior this one axillary line and mid-clavicular line. So you can use that space between 8 and 10. This is called zone of opponents, wherein you have a proper window where you have seen the maximum thickness of the diaphragm. So this is basically, you have two, if you see, you can put a caliper, you can put calipers, and both inspiratory as well as expiratory thickness you can measure. So there are two hyperechoic lines, if you see. One represents the pleural and another represents the peritoneal membrane. And the middle hypoechoic line is nothing but the thickness of diaphragm. So you have to put the calipers, electronic calipers. So if you do it for research purposes, what you can do is you can just mark the space, mark the area for future readings, so that there is homogeneity in your readings. The same point you can choose. So this is how you mark that area. So why I'm focusing here on diaphragm is to have a good objective measure whether you so that you can aptly choose the intervention which can mimic the ill effects of mechanical ventilation. So if you know that diaphragm is the most susceptible muscle, so you can plan from the beginning, you can plan the strategies which can help in strengthening of diaphragm muscle. So they have a lot of clinical implications. So you can plan strategies, you can predict the duration of ventilation and status of weaning also. If you have in the beginning also, if I told you transdiaphragmatic pressures less than 10 centimeters of water tells you about poor outcomes. So you can expect that the patient will be there for on mechanical ventilation for longer duration. And the best part of this technique is you can even employ this in sedated and paralyzed patients, because you don't need patient cooperation in these. So patient can be sedated, paralyzed, you can still have measurement of all this transdiaphragmatic pressures and diaphragmatic thickness. This is one more important. This one is an objective method. So you can quantitate. You have that this much thickness at this point of time, and after 1 week you have this much thickness. So you can quantitate. This is a non-volitional evaluation of diaphragm. This has been found out to be more reliable than other methods like maximal inspiratory pressures, which has been traditionally used in intensive care units, and it is very convenient to use. Actually, the gap in between, wherein you can find that there are not much studies pertaining to this, and the majorly it has been found out to be like the skill associated with it. So there are people who are hesitant in carrying out this, but in reality when you get into it, it's not very difficult. It's just a few cases you may experience difficulty, but once you have hands on it, so it's very easy. It's not difficult. So I would like to conclude by saying that for effective patient management, it is always better to have a good understanding about the diaphragm muscle, so that you can plan the weaning of the patient, the future course of the patient, as well as the amount of support he will need post operatively. So esophageal pressures can be safely monitored, utilized for diaphragmatic muscle strength even at bedside, so you don't need special equipments for that. It is a variable tool definitely available at present to assess the thickness. So it is convenient as well as reliable. So thank you so much for listening to me. I've just I've just shared the experience I have done since last 3 years. We have done a study in this, in which we have taken around 52 patients. We have screened 273 patients, in which we could only include 46 patients. So one of the biggest criteria, one of the main criteria was to have the consultant who is in anesthetist there. He has this one notion that this patient will need mechanical ventilation more than 48 hours, because for smaller duration of this one, there won't be much changes in the diaphragm thickness. So whenever you have that anticipation, and the most important thing I want to add here is, there are only 6 patients in whom we could wrongly depict that this patient. So we thought that this patient will have 48 hours of more mechanical ventilation. So they got extubated in 30 hours. So rest in majority of the cases, whatever was predicted earlier, it came out to be true. So wherever you have that notion in your mind that you have a patient and he can be there for longer duration on mechanical ventilation, so definitely from the beginning you try to evolve those strategies which can help in strengthening or prevent the disuse atrophy of diaphragm. Thank you so much. Any questions? Yeah.
Cardiac also, there are long intubations and extubation is a thing to deal with. There was what I'm getting, and I think you'll be able to answer, would be we have specifically quoted if this much hours of PRBC or SIMB deteriorates diaphragm strength by this much percent.
Yes.
So getting that.
Yes. See, actually, it has been
Specified in the morning, 24 hours of ventilation on PRBC or controlled mode. It reduces 9% strength of that.
see.
How much?
9%.
9.
See, I have told when I talked about this, I told there are so many factors, even the duration of mechanical ventilation and the mode of mechanical ventilation. Patients who are on controlled mode ventilation, they are more prone for, because they are unloaded, totally unloaded, so they are more prone for disuse. But patients who are on PRVC mode, doesn't mean that even they are on PRVC mode or volume control mode, in them also we found out the rate of decline is less as compared to the control mode ventilation, but rate of decline is seen in them also. So it's around 9 to 18%. 9 to 18%. It's a variable population. Now, one more thing to keep in mind is, see, in CTVS, like what we have is, you have a CABG patient and it has been predicted. First, you predict that the patient will be on mechanical ventilation for 6 to 8 hours or 12 hours. But what patients we encounter is, we have seen patients on mechanical ventilator for 2 years. We have a patient who is since 7 years who is with us, so is still there. So why I want to convey here, it is not only one criteria on which the mechanical ventilation duration is based. It is I have told you, it is the bridge. Unless and until your underlying cause is treated, you cannot take off the ventilator. So keeping everything in mind. So if we have a patient,
factors like oxidative
yes,
stress,
yes,
metabolic
everything. So I'll give you an example. We have a patient in trauma wherein he had splenic injuries. He had EFAS positive. He had splenic injury, and he had multiple rib fractures. He had spine fracture, and he had 2 fractures in the femur. So what needs to be done? The plan from orthopedic team is they want to operate femur, they want to fix the femur. The plan from spine unit is they want to fix the back. So you can't just extubate the patient and next day he will get re-intubated for spine surgery. And after 2 days, now orthopedic people will say, now we have to take him and again re-intubate him. So in those scenarios, you need to time accordingly. Or patient who has splenic injury and grade 4 splenic injury, he has undergone splenectomy. So their chest slowly gets deteriorated, and we found, and majority of the patients, if you see, they go for ARDS. So once the patient is in ARDS, you have to completely unload his respiratory muscles and all, and it is very difficult to take them off. Hope I answered your question.
Did you come across any hemidiaphragm patients
Yes.
where the same applications can be applied for the consideration of their mechanical ventilation strategies?
Yes. So, if you remember, we started in 2004. You and me, we started doing diaphragmatic stimulations in ICU-B, but unfortunately, we didn't had much. We had only 5-6 patients. I think in that 6
When
months,
the lima was being harvested for the
yes,
first
yes,
time,
ma'am.
Dr. Khan was doing
Yes, and we had 8 patients. We had 8 patients data that time, and we directly stimulated in this 8th and 10th intercostal space. And believe me, without knowing what we're doing, so we did it. We had some idea, and we that time also we found out that we could wean these patients, and we had taken serial X-rays because in them they had documented phrenic nerve injuries. So we could see in 1 week's time.
And we did cinefluoroscopy
Yes,
also.
and in 1 week's time, you could see that hemidiaphragm, which was up and flat, it has come down. So here in trauma center, in this meantime, when I was doing my PhD thesis, I have taken one patient for phrenic nerve stimulation who happened to be an IAS officer who was C5 injury. After 2 years follow-up also, they could not wean him for at least 1 month. And after that, I got a call from spine people, and they said, we want to wean this patient because he's an IAS officer, so we want to make him this one. So I did almost 15 days of phrenic nerve stimulation, and on the 16th day, we took him off the ventilator. And I have presented this in Trauma 2022, and that case. And after 2 years follow-up also, he's alive and kicking without any reintubation, and he's on room air. So
It's very interesting, like the right hemidiaphragms are still doing well. Yeah, in CTVS also we did, but only thing is, because with the right diaphragm, the patients were, hemidiaphragm, the patients were able to be extubated and they were weaned off successfully and they get discharged. So the follow-up is very important in such cases. I remember one such case, Dr. Balram's total correction, and he had a phrenic nerve injury of right diaphragm, and he belonged to Kanpur. And when I went to take an exam, he just read in one of the newspaper that, and he came to meet me there, and for 3 days he took phrenic nerve stimulation over there also. I started there also, but the follow-up is very important. A long-term follow-up and the apt follow-up. We did not have any strategy how many sittings it will take, and what are the timings, what are the dosimetry. We were doing only with a minimal milliamperage.
Yes, sir.
We did it for 3 patients.
Okay.
Yeah.
But our results
Our results were not there.
Okay. So
results
if
for
you
only 1 patient.
okay,
But we could do only 4 or 5 sittings in those patients because these patients got discharged.
actually, before taking this topic, I was very hesitant, doing cranial nerve stimulation, and I don't know how many of you have see. There was a this one Anders P. He is one of the pioneer for diaphragmatic pacing. He was invited to Indian Spinal Injury Center. He has come here. So I discussed it.
He uses invasive method.
That was in 2018. So what I did is I met him. I told him I'm planning to do this.
Last year also he was here.
He
Had
came.
the same spinal cord.
Yes,
He did
yes,
a
yes.
workshop
He
there.
did 3 surgeries here
Yeah.
at that time.
But he uses an invasive method.
He uses invasive method. But I tell you one thing. It is not invasive if you say per se. They say, according to him, he says it is an endemic. It is an epidemic type. If you have this diaphragm is very important. Say if you are doing a CABG surgery, you are doing sternotomy. So there's no harm putting 2 pacing wires there. So you can put 2 pacing wires there, and regularly at 2-3 times in a day, you just stimulate it.
Sensitization. Yeah. Getting more open and sensitization.
Okay. So it is only when you specifically go for putting the pacing wires, and then it becomes invasive. But once you are through, say for example you are going for laparotomy, open laparotomy, wherein you go up, very up, you can visualize the diaphragm. You just put 2 pacing wires there and then attach it with the. So they say it is now in US. They say that we want to make it this one, that in patients wherein we expect that mechanical ventilation duration is more, we will put at the time of surgery, we will put 2 pacing wires there and pace the diaphragm at regular intervals. That will decrease the time of mechanical ventilation. So is the impact of having diaphragm function proper at proper intervals. So I think
the interval stimulation.
yes, intervals. And the interesting part is the majority of the study, 3-4 studies, is in CTVS.
Yeah.
After cardiac, there was a study by Ahan et al. And they have done study in 18 patients. During the surgery only, what they have done is they have put 2 pacing wires, cardiac surgeries. They have put 2 pacing wires. They have done stimulation of 30 minutes at 2 intervals of 2 hours intervals of time, and they found out that they could easily wean earlier patients. And they also did a cadaveric this one also, wherein they found out that the thickness of myofibril was high and the myochondrial function was also improved with stimulation. That is the reason basis behind stimulating at regular intervals. Thank you so much.
Thank you so much, Dr. Altaf. See, breathing is so fascinating. Anything related to it always fascinates. We have also tried this stimulation when you left CTVS. After that, we tried on a few patients, but didn't get much of the success there. So, but this is always fascinating. Yes, this diaphragmatic stimulation in itself is a very exciting subject. Yeah. Maybe someday we can collaborate something and start doing it again.
Further study,
Yeah.
it requires time and patience.
So this time we can upgrade to invasive one maybe. No, there are small needles. I've seen that they've been used. Yes. 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 Now actually, it is time to see, accidents can happen anywhere. So now we can. This is a time when we have to thank our sponsors, and the BTL team is here with us. They are here. They have some small representation. So let's see what they are here to offer to us. Let's come.
Can you restart? हो नहीं रहा है आपका. Shall I restart? चलो नहीं पा रहे. नहीं ले रहे. देख लिया. एक इसके एक
वो ठीक है सर, बाकी वो भी कनेक्टर है जस्ट वेट, हमारा कनेक्टर सभी दोनों कनेक्टर लाके रखा उधर रखा है, नहीं ले रहा, चल वो ठीक है, नहीं उसमें ना हैंग हो जाएगा, उस तरफ करेंगे, इसमें लगाओ सर। एक टेक्निक ये भी क्या हुआ, नींद अपना लेफ्ट एचडीएमआई पोर्ट ले नहीं रहे,
इस वाले बंटी सर वाले में डाल दो।
हाँ इसमें लगा, वो पेन ड्राइव इसमें लगा, चल रहा है ये, हाँ बट डायरेक्ट नहीं चल, रिस्ट्रिक्शन है कुछ, हाँ सर ले जाइए, ऐसा प्रॉब्लम यही है, हट गया ना एक बार बंद हो जाएगा, आ गया ना, वो पेन ड्राइव इसमें लगा लेना, कितनी देर बाद वही बोल रहा, कितने मिनट का 10 मिनट, आ गया, अच्छा अब अभी अन्य तो 12 last pen. Okay, let's begin. So you can use mic. I can use the mic. This one. Good afternoon.
Thank you once again for giving us an opportunity. And I know that we've reached a threshold for hunger because it's almost 2:20. So I'll quickly finish my presentation. And before I go, let me, since I'm from South India, so generally I'm a fan of Vijay. So let me start with a small kutti story. Okay. BTL. In the year 1922, two people in a small garage, they wanted to do something so that Thanks, Dr. Manas, for a nice presentation of your products. And I would like to thank all our colleagues and seniors for attending this particular CMA based on non-invasive ventilation and making it a successful event. Thank you so much, all of you. Now you may have lunch. Thank you.